Is anybody there?
Good morning.
Morning.
Good morning.
How are you doing?
Well, all right, I think. How about you?
We are almost all set, yeah. Just a couple of minutes and then we will be starting.
I don't see myself. Weird, I can only see Mark in the camera.
Maybe your view? Select a different view option in the upper right corner.
Let me try it.
Good morning, Avery.
So 3-4 more minutes. Mr. Everydeni, Professor Everydeni is with us, and we are just looking towards you, Dr. Mark.
So at least the first couple of us to speak are here and present. Do we know if Dr. Russell is joining?
I believe so, Mark.
There we go. All right. Well, good morning. Welcome everyone. Yate Abine for the Diné people in the attendee list. This is the Conference on Emerging Infection in Tribal Communities. It was organized by Professor Shazia Hakim of Diné College with Dr. Joseph Angel de Soto and Barbara Klein. You will hear their thoughts and reflections toward the end of the afternoon. Funded by the American Society for Microbiology. And basically to foster broad sharing of the challenges of the COVID-19 pandemic and the latest scientific findings and strategies for the future. To begin though, we'll begin with an opening prayer. I'm very honored to be introducing one of the college's most revered traditional practitioners, knowledgeable in a number of important Navajo ceremonial ways. Professor Avery Diné has taught in our Navajo Studies Department for over 20 years and makes our college events very special with his traditional prayers and songs. Professor Diné, I'll hand it over to you. So the lower left-hand corner, if you put your cursor over the lower left-hand corner, do you see the little mic symbol that you can click there? Michelle, do you have any advice for us here?
Dr. Avery is unmute from our side.
Avery, it's your turn.
Yes, he can't unmute, or he can't get his microphone isn't.
He is unmuted. I don't show the mute button on there. It's just that he may not have his volume up. Avery, right next to your microphone, there's a little up arrow. Select the microphone that you're using. There's an up arrow right next to your microphone. You should be able to select the different type of microphones.
Yeah, Professor Avery, on beside your
Avery, can you hear me? Nod if you can hear me.
It might be best if Dr. Avery will call in and then via his phone, he can do what he needs to do.
He's connecting audio right now.
He put a phone number in the chat if somebody with technical expertise could give him a call, maybe. Yes. Someone suggested that he leave the meeting and come back in, and maybe that would reconnect. Yes. I appreciate everyone's patience while we try to work through this technical issue here that came up in spite of all of our previous testing.
Avery is dialing in, so he should be joining us soon.
Okay, I see that we've had a number of other people join us. I'll announce that we are welcoming you to our Emerging Infections in Tribal Communities conference. And we are waiting for technical assistance here to be able to have our opening prayer before we go on with the rest of the program. And Dr. Hakim has kindly put up some guidelines. So those of you who are registered and have signed in will have, your mics will all be muted to keep the sound good for the speakers. If you need to ask questions, there's a question and answer button at the bottom of your screen. And for the most part, those questions will be answered either at the end of a presentation or during a special question and answer period that will be at the end of the morning and again at the end of the afternoon. When you're posing questions, make sure to give the name of the presenter that you want to pose that question to, because sometimes the questions won't be answered until later. And of course, we have an evaluation survey at the end of the conference that we hope everyone will fill out. And there are fillable attendance certificates that you can generate at the end of the meeting and for a couple of days afterwards.
So this is Dr. Hakim here. Just to add that while you will be able to download your fillable attendance certificates, they will be available for a limited time period between February 20th and 22nd. So those of you who are attending can go to our conference webpage. You can download those certificates just as a memory that you are attending this conference from here, that we are hosting from here, that is Diné College. Collectively, like we have 6 campuses here at different locations of Navajo Nation. Some are in state of Arizona, some are in state of New Mexico. Our main center is basically located in Tsaile, but like we have some other campuses, including Tuba City, Shiprock, Chinle, Crown Point, and Window Rock. So whenever you have time, and if you like to know more about our college and the Navajo Reservation, variety of things you can find out on our webpage, feel free to visit and join us whenever you like for different type of occasions and events that we used to have frequently. Hello. Yeah, we are trying.
Hello, Avery. Avery, you can go ahead and start.
Okay. Mark, can you hear me?
Yes.
Okay, I can hear you, but I'm on the phone now. Good morning, everybody. I'm way down here in the rural area, a place called Round Rock area. I'm sitting in my hokan here. I was trying to zoom in. I think I blame it on the Mars landing yesterday. All this is going haywire. So it has something to do with science. There's always a glitch. But today, yeah, that's not our focus. I've been given to do the invocation. So that's what I'm going to do now. I'm sitting here. I got my ceremonial items on the ground here on the floor. And then I got the fire going here at home. And with the Navajo nation and throughout Indian country and other civilized nations, we are in this crisis of the pandemic, COVID-19. So we're almost at the tail end. I would like to believe that. And thanks to science, technology, and research, and coming out with a vaccine that seems like it's going to help. Yes, we're going to begin to be all right and be comfortable, be able to go around. But there's the healing stages and the aftermath of what happened. Millions of people died, lost their family, whole family disappeared. So the survivors, what they're going through is going to be huge with mental disorder condition being dramatized, and it will take a special psychology, a special hands-on intervention with different cultures and how we're going to proceed and how we're going to do it. We need all the help with science, holistic healing part of it, and traditional counseling and counseling all the way around. So medicine, so that's where we're at, and we have a dialogue and talking about this, and so we need all the prayers and all the help. So spirituality, I know science don't have room for it, but we have to make room for that because we're dealing with human nature and feeling. So we have to think about that. We're talking to human lives, human soul, human mind. So we have to make that, transcend that, and kind of like touch the heart of survivors. And today, this morning, that's how I'm going to do my prayers to help our professional people, the one that's going to do the presentation today, have a research insight, what needs to be done, and all the data that's collected, and where we are and which way we should go. And we need all the help. So my prayer is going to go along that way. So just bear along with me, and I'll start now. So I hope we have a successful day too. And I'm going to start now. And usually Navajos, we start with a song. So that's what I'm going to do, because you can actually say there's sickness, there's disease out there that's like, they have their manifestation to stay alive and fight for their survival. And here we're going to confront that and try to execute our plan and to get rid of it and not leaving any behind, and just extinguish them. So in our survival, we have a manifestation to overcome these dangerous times and survive. So that's how I'm going to use this song. So it's a warrior song. So I'll go ahead and do that. Hey, she can sleep, oh, she can sleep, na yediz vanishing sleep, oh, she can sleep, on best she can call. She can sleep, on best Jesus call. She can sleep, on best Jesus call. She can sleep, on best Jesus no linning na she call. She can sleep, on best Jesus she call. She can sleep, on best Jesus shoski na dotza call. She can sleep, on best Jesus it's not a shackle. She can sleep, on God's and she call. Best Jesus Besta Hisle Gola, she can sleep, on God's and she best Besti go sits on my head, Gola, she can sleep, on and then I hit it to your chin sits on J, na ye chart in the deck, Gola, she can sleep, on and then I hit it to your chin sits on J, done the choy, yo ya a leg, Gola, she can sleep, on a cabe, done the choy, pay on the zen, shippick at the street, Gola, she can sleep, on and then I hit it to your chin sits on J, na ye, pay on the zen, she not it, Gola, she can sleep, on a casa, na open the hot city, Galashin the sling, Gola, she can sleep, on a page, she can sleep, she can sleep, hey. Yoske sta, the Yazus sanat lehe, but so Mishling got the snare. Now yet there's run, Mishling Hobajushin, Slodishin, Tunat lehen sle, say Yahnayan, Mishling got the shin, Johanna Ashitra got the snare. Now yet etashil inko, now yet Shenal Zedko, Atishne, now yet she otenteko, Atishne. Na ye big etishlinko, etishne. Dite big echo, di the cohol jishigi bigi. Di ya Tsaile hol yeke. Then college hol ya bigi qua. Kotel klehoneski touch a yarn la. Arokodok ahades a, and no sepelash la is cage a k, Tuisani. All different denomination of people, hot argon long, bohodit ekon, ishi ni khaynis ito hot ite ishi nas ni to thani ka ete ni thani ya ni ko ni ya ko big o youth ne petenite belash laitan no laita zi khaj tahzli ko kade kode epet age nish beta nish sto ite halet adol dihla big etiti tlis big ta pa tahoteni nas big khacho dit ego benya hilte hot argon lo konde we're going to talk about these things, issues that we have, problems that we have, trying to find a solution today, throughout the day. Research or medicine as the counseling, know how to use words, the right kind of words, the right kind of thought, what is going to be the one that's going to help our people, to comfort them, to have love for them, passion. So we can't just treat them like specimens. They're human beings out there that are hurt, hearts are felt. To kind of like make that mental, emotional connection with souls of people. What is the right procedure? What is the right approach? How to gain trust from these victimized survivors today. What is the appropriate medication, the appropriate vaccine? How are we going to be next year, 2 years, on down the line? That we're going to have a plan, a strategic plan all the way. That we could kind of like draw our weapons, bring them out, and use it like that. We have all these kind of knowledge, wisdom that we can use to battle this crisis today to save our lives here, of loved ones, that we could all come together today and have a dialogue and have a debate of certain things and come to a conclusion what would be beneficial for our Indian people and other civilized nations throughout the whole world. That we could go in the right direction, approach, not going backwards, going forward. I use the song, I use the prayer, so there's na ye tan kigo ni osentel ni la je tati no bi ye astati kha khon na ye ya dan chonki ni hisi na ye ya dan chonki ni hisi ye shen ha ye shen ha ye shen ha pa. So that will be my prayer, folks, relative. Ade, Mark, your team, Barbara, thank you for inviting me, and all the other colleagues that we work with, and then all the guest speakers that's going to be throughout the whole day, talking about their point and their perspective. So I say, like, let's go do it. Let's not just talk about it. Let's go do it. Let's not talk in circles about it too. Let's go do it. So enough talking about it. And that's why we already know who this is, what this is, and we need to tackle it, and we need to do something for ourselves. I stand by you and stand beside you here. So that's what I would like to say this morning, and have a good day. Greetings to everybody, and thank you very much. So stay healthy, be well, and be happy. Enjoy our day today. Thank you very much.
Yeah, thank you very much, Avery, for your words, for your song and your prayer, and setting the stage very well for for our conference, coming to all of you from Diné College, the Tribal College of Navajo Nation. Our welcome this morning will be provided by our college president, Dr. Charles Monty Russell, who became president in 2017 after many years of experience in educational administration in Indian education and with reservation schools. He's been leading the college towards its current status as a four-year institution with 8 bachelor degree programs. He's always been incredibly supportive of our science programs. Dr. Russell?
Thank you, Mark. Good morning, everybody. As Mark said earlier, we practice and practice, but there's always a glitch. But I actually think Professor Diné was just waiting for the number to get up to around 250 before he started. So exactly. My name is Monty Russell, as said, president of Diné College, Ke Ani Nishle, Monteith Clan of Scotland, Bushes Chain, Ashin Shache, Auto German Chanela. I've been here for 4 years. And, you know, as we all have been shaped in this past year, it's really shaken, I think, some of the beliefs that we've had and some of the thoughts that we've had. But as Professors Diné prayer and song reminds us, there are some things that are unshakable. And I think the mission of this school, the foundation of this school, coming from a certain perspective, is one such of those anchoring tenets for us. Well, first of all, welcome to Diné College. If you were here actually at the campus, you would be surrounded by about a foot of snow. The trees are still hanging heavy with the snow. It's cold. On my walk to the campus this morning, it brought tears to my eyes, but good tears from the cold. And I know that a lot of people out there are dealing with it, and our thoughts are with them also in that area. It is my pleasure and honor to speak with you this morning. I do not need to tell you that these are difficult times for all of us. Here we are still in the middle of the pandemic, and we are seeking answers and pursuing lessons learned. The idea of timing and time has never been more fragile. But before I begin, I would like to thank the Diné College team who put this conference on. Dr. DeSoto, Dr. Klein, Drs. Bowers, Bender, Tutt, Verma, Boyd, and the entire staff and faculty of STEM, as well as Dean Tutt. And I'd like to specifically thank Dr. Shazia Hakim for her tireless work in organizing this event. Over the last week, I have received more emails from Dr. Hakim than any of my children and grandchildren combined. And I just welcomed a new granddaughter a week and a half ago. So thank you to all of you. This topic is not only timely, but it is critical to the safety and well-being of our Navajo Nation. Before you get into too many of your discussions of detail, I'd like to share with you a brief history of this college, because I believe it's foundational to why we are here today at Diné College. As mentioned earlier, our mission and philosophy merge with our visions of future, and this conference is reflective of those ideas. Diné College was created 53 years ago as the first tribal college in this country. Back in 1968, then Chairman Raymond Nakai brought people together, the BIA, other leaders, and told them at that time, we are going to start a college. The Navajos are going to begin a college. The people in that room laughed at him. They laughed at the Navajo Nation. They said, my God, Mr. Chairman, you don't mean to tell me you Navajos think you can run a college. Chairman Nakai looked around the room and just simply said, I'm not asking for your permission. I'm telling you what we're going to do. I think that story is important because from that time and times before, our leaders have come forward. And it's not about saying we have to prove that we belong at the table. We've earned that long ago. This conference is reflective of that. The founding principles of Navajo and of this college, that this is not an either or, either the Western philosophy or the Navajo philosophy, but this is a both and, that we can combine both the Western knowledge and our Navajo knowledge and combine a larger way of knowing. And this is what is important about what we value here at Diné College and why this conference is reflective of that. This is about knowledge shared as a spectrum and not an entitled ownership. There is a continuum between traditional knowledge and Western knowledge. It moves based on perspective and situation. One of the things that we are trying to do here at Diné College, as well as the Navajo Nation, is build capacity, build the human capacity that is able to address these viruses of the future, but also from our perspective, to address the challenges it faces from a Navajo viewpoint, but understanding that combined we are stronger, that this shared spectrum is something that we can actually be stronger, as Professor Diné mentioned earlier. This is what we're trying to create at the college. Back in 1968, they called then Navajo Community College the higher ed institution of the Navajo people. Along the lines, the founders were thinking about how do we meet the needs of our Navajo people and the Navajo Nation. Those are two distinct questions. And when we come to something like we're dealing with right now, a pandemic, it is even more important that we build a capacity from within to deal with the challenges from within, but understanding that those challenges are also coming from outside. This is how we're doing that right now. This month, Diné College just approved the new biomedical degree to provide a door into the medical field for our young people. We are also developing a physician's assistant's degree. And our students are taught research methods rooted from an Indigenous perspective. Many of our public health graduates have been working on the front lines of clinics and hospitals. Our current students, some of them are working with Johns Hopkins doing contact tracing, and others are working to, in the simple words, meet the needs of our Navajo people. We are proud of these efforts, but it is just a start. As the nation's college, we are exploring new opportunities for our students and faculty to be a part of these conversations. We seek partnerships with many of you to expand our knowledge as well as your knowledge. This is a two-way street or a two-way dirt road. So often in Indian country, we are set aside and forgotten. History has shown us that in these times of crisis, we all talk about tearing down the boundaries and working together. And so it has been with this pandemic. We know that viruses know no borders. They do not stop upon entry into this country, into Arizona, or into the Navajo Nation. Yet our actions do not reflect this knowledge. In other words, the time to come together is not just during the pandemic, but the voices of minority communities and tribal nations are worthy of hearing and discussing before a crisis begins. We hear a lot about equity now, but we all have different definitions of what that means. As many of you know, roughly 30% of Navajos have no running water or electricity. How do you start a conversation about equitable solutions when the disparities are so great? It is my hope that conferences like this will help change that conversation. What is unique about this conference is that it is originating from within a tribal nation, the Navajo Nation. and it is being hosted by the nation's college, Diné College. The joining of experts from throughout the world to explore, as the title of the conference states, emerging infections and Indian communities, what we learned from COVID-19. We all know that the Navajo Nation has been hit extremely hard by this pandemic. Our college has been hit hard, from losing students and faculty to educational futures put on hold. There has been a tremendous toll on our people. That toll will not be realized for years to come. Aside from the physical challenges, there has been a great emotional charge that has yet to be counted. One area that is being ignored right now in Navajo is a negative impact on the education of our children. We need a convening to meet this pandemic of inequity that is plaguing our educational system. Our students are already 2 to 3 years behind, and now that may be 3 to 4 behind. How will we make up this lost learning due to COVID-19? I understand that this is a different topic from today's conference, but it is important to remember that ripple effects in most places are a tsunami in Indian country. To say that the research of COVID-19 is just beginning is an understatement. Its tragic impact is far-reaching. There are a lot of reasons for this, and it will take years to drill down and see what were the real factors that contributed to this. Our Diné College has a Diné Policy Institute, and it is currently undertaking a comprehensive study to look at what were some of the causes and results of decisions made and decisions not made. We are looking at the policies that slowed responses, their traditional impact on our traditional knowledge, and the economic impact of COVID-19. We are looking at that through the lens of our Navajo perspective. Earlier, Professor Diné talked about the human element, and I want to share a couple stories that remind us why we're here. Almost a year ago, a student was not feeling well and went to the hospital. She was quickly admitted and wasn't really sure what was going on. This was in March. But her primary thought was, I have a class in 30 minutes. She contacted her professor and was told, don't worry about the class. Take care of what you need, he told her. When the class started 30 minutes later, the professor was stunned to see her zooming from her hospital bed, so she did not miss class. When reached later, she said simply, quote, I'm earning my degree, period. The other story is from a student who sent me an email just to let me know how she was doing. Looking back, it is hard to imagine what a new email would look and sound like today. This one was from May. I currently work here at the Indian Health Service and had to move away from my family to prevent bringing this virus home. It has been hard being away from my 9-year-old daughter, but I love her too much to hurt her. I just wanted to share what things have been like here in our facility. At the beginning of this pandemic, it seemed that no one was really talking and taking this whole thing seriously. Now today, it's a whole different story. I attended a meeting this morning and found out the Navajo Nation cases are skyrocketing. My heart sank into my stomach. We are now told to wear N95 masks throughout the hospital. We can't see the smiles of staff anymore. Office doors are now closed to ensure social distancing and the hallways are quiet. Preparations have been made to increase beds in our inpatient wards for a possible high influx of COVID-19 patients. Remember, this was back in May. Medical helicopters are landing so often it sounds like a war zone outside. Several staff shed tears in fear. Some have no emotions. And we even have had some resign due to fear. All we keep asking is, when will this end? We are doing our best to be here to help patients. However, it is very hard. Through all of this, it has been a struggle to concentrate on homework. I'm working extra hours and it does drive a wedge into studying. This has been the biggest challenge in my life, having to leave my family, being in the middle of this devastating pandemic, working 10 to 12 hours a day, including weekends, and taking full-time classes. It's a lot to handle, and at times I forget to eat, but we are managing. I do pray morning, noon, and night that everyone is safe, and I only wish the best for all. I wanted to share what it's been like for some of us healthcare workers. We are a resilient people. We will get through this. I share these stories not to tell you how special our Diné College warrior family is, though they are. I share these stories to remind you that this is why we are convening here today. We talk about the virus because it is about people. It is about our future. Our tribal nations are partners in solving the challenges of today. Our voices matter. And although this is about a virus, it is also about economic well-being, education access, adequate healthcare, and so much more. This is not new to the Navajo Nation. Our culture and history teaches us that all things are related, even COVID-19. The knowledge and this knowledge also drives us to seek answers that go beyond the confines of the obvious, to find solutions and to learn new lessons and to meet the needs of our Navajo people. I want to thank you all for being a part of this conference. We hope that it'll be very successful, and we invite you to come and visit the Nations College, Diné College, whenever you're in the area. Thank you.
Thank you so much, Dr. Russell, for those wise words and for your vision for this college. It is now my incredible honor to introduce the president of the Navajo Nation, President Jonathan Nez, who was born in Tuba City and raised in Shanto, both in Arizona, on Navajo Nation, has a Bachelor of Science degree in Political Science and a Master of Public Administration from Northern Arizona University. He began his current term as president of Navajo Nation in January of 2019, and since taking office has advocated and supported the priorities of Navajo communities. During this pandemic, he introduced aggressive measures to reduce the spread of the virus among Navajo communities and has been on the front line speaking with first responders and visiting Navajo Nation's 110 chapters to gain a firsthand perspective and offer support. So now I'll turn this over to Jonathan Nez. Thank you for being here.
Good morning, and thank you for that introduction. And Mr. Diné, Nachatsodin Zendo Tsaile, Nachan Dr. Charles Monty Russell, Nichihensi do Ade, Nihikeni Hidna, Danihinatigi do Daisnolsagi, Jadi Kodo Nahaho do Hadits Hadnigi ba Hinson, do Hela Winson, Jo Kodo e Yan He, Nihikeni Hidna e Yisi, Kodo Nihikai Je. Nihikeni Hidna Kodo da Istan Hinat Ani do Zel Indan Lo Kodo Yiken da Zon Di Nashnigi do the Kosenskagi Nahas Ada Benach Beachedi Kahota Hadainofne just cannot Sada Edo do Jocho de Ida the sea clean da Conde Kodo Pada Altra Gido Hinat Ani Dan Lenigi E Kodo Yen Dan Tin Jo Ebony Na E Con Diné College Ilya Nhe ol inloni na antin. Khalchin. Bilbeda hasn't do le no jo without a yan how zi. Ado benach. Chana ni lido ben hitzi naso net nij. Eshi benach kodo he dan hidi nido lesh kedo shna nihidene ade nihina nishidalla benach kon ashon nalni gi yakon niltene bike cow. So ashil tzo kodo the neck catching hit hasi do le she hin shlont nesani bashish chindo twede chini da shichido tchini da shinala. Shant tode yisina sha do ade chishikit ahandi ade kesht ido ahandi tunda hiki hoda la shindo on hisbeda hazanda ahandi ya shimado shije kesht ingi ahandi oda ke huite akonde benach hit ziloda la shewat ani yada ho la shia ahandi oda keda hot man benach hit zil kinana antine hot elne yegon as yajish we hainlne binaga da nana jo hot kon the college aj dal nashigi do not dan lenigi edo hot dan tinoda ishin be dan hit zil do le legend do and shiko yije kod neto les. Good morning to everybody. I just wanted to say a few words in Navajo. Of course, you have a Diné college, you might as well use your Diné language, correct? So I wanted to encourage our Navajo citizens out there in the Navajo language about the outstanding work that they have done throughout this pandemic. You know, as a servant, as a facilitator, you can only do so much unless you have the support of those that you serve. And being a leader of the Navajo Nation, the support of the Navajo people was critical to get through when we're transitioning and we're praying that we get out of this pandemic. But I just want to commend the Navajo people for their support, their prayers throughout these difficult times. Of course, we had some very strict protocols in place, and many people, some have pushed back, and it's quite discouraging that it had to get politicized. You know, wearing a mask shouldn't be politicized. It's about taking care of yourself and taking care of your family members. It's not restricting freedoms. It's being a warrior, right? They're not college warriors. The Navajo people have been and are still today warriors. So if you're going into war or you're going into battle, you have to be equipped. You have to have the armors, you have to have the weapons. And I'm sure a lot of this type of discussion will be shared with you today. But first of all, let me just say thank you for the invitation to say a few words and the opening remarks for the conference, the emerging infection and tribal communities, what we learned from COVID-19 pandemic. Who would have known, right? Who would have known when we took this post or we got elected into this office that we would be serving through a pandemic. And I think truly with the help of everyone, including the college, that we did our very best with the limited resources that we all have. You know, I mean, you've heard stories of how we had to fight the federal government for our fair share, if you want to call it that, of resources. Who would have known we would take the federal government to court? CARES Act funds was supposed to be relief and aid to tribal communities throughout the country and the states and the citizens of the United States of America. But yet the first citizens of this country had to wait. And President Russell mentioned that first big wave, we had to do a lot with our own resources while we waited and litigated for our share of resources from the federal government. But we didn't roll over. That's the resilience that was mentioned today by the opening prayer and by many of the presenters. I'm sure will share. We didn't give up. And we've never given up as a Navajo people. We've heard the stories since time immemorial to today, with the hero twins coming in and protecting the Navajo people from these monsters. And I've heard presentation from many at the college, from Professor Diné and many others about, our way of life teaching. And I think that was critical in our messaging here on the Navajo Nation. We framed it in a way to where our elders understood what we were going through. It wasn't about this plague, infection, or this virus sweeping from another country. It was about another monster entering the Navajo Nation. The hero twins had the armor and the weapons to fight off all these monsters. And we heard these stories, and some of the college students that are listening today, you got the monster hunger, poverty, old age. You remember those stories. I remember those stories as I was growing up. And now you fast forward to today, and we have modern day monsters: alcoholism, drug addiction, depression, suicidal thinking, cardiovascular disease, diabetes, and now COVID-19. See, these viruses have come onto the Navajo Nation. And we've heard stories as far back as smallpox, tuberculosis, just recently hantavirus, and now COVID-19. And we have to prepare for war or these various battles on the nation. And so when we were messaging and getting information to our Navajo people, it was about preparation. For instance, wearing a mask, that was armor. It wasn't about limiting people's freedoms. It was about protecting our families and our people. And so when you put on a mask, that shows that you are a warrior. And that mindset today, you go out into the public, you see our Navajo people wearing masks. We had to have a mask mandate back in April of 2022, and it's still in place today, so that people can see that the nation was serious about this pandemic. And then many of the information that we received from healthcare professionals, leaders, wearing your mask, social distancing, washing your hands with soap and water, using hand sanitizers, and staying at home. Now think about that, staying at home. People will say, well, you're telling us to do something against our will. But if you look at it in the Navajo lens, home is the safest place to be. Home is where the origin of planning, law, policy comes from, and the most safest place to be. So in a way, it was a reset for all of us of our way of life teaching. And I think really when our children were told to stay home from school and our parents were at home, a lot of the teaching was handed down more so through this pandemic than I think ever before, because that's what we challenged or encouraged our Navajo people to do. While your children are at home and the protection of your dwelling, teach our way of life, teachings, tradition, cultures, and even our language. You know, back when this pandemic started coming on Navajo, we challenged our Navajo people to go out and resurrect some of these old farm plots, to teach that to our young people. The teaching of hard work and overcoming through challenges, rather than just staying at home, thinking of this pandemic as and stay home. It was more of a challenge to get outdoors, stay active. You know, I could go off and say a whole nother 20 minutes about our health and well-being. You know, this virus really targeted our most vulnerable population, those that have health problems. And, you know, there are so many reasons for these health disparities here on Navajo, but it shouldn't be an excuse and to feel sorry for ourselves. We call ourselves a place of food deserts. Well, rather than say that we're in food deserts, what do? We got to grow our own. And we also got to challenge the federal government as well. You know, we lost a lot of folks that had cancer. Where did this cancer come from? The over 500 open uranium mines plays a factor here. And we just recently received some support after much advocacy, $220 million to clean up over 50 uranium mines here on Navajo. You know, we help this country and this world on two fronts. Navajo, we all know the story of utilizing our Navajo language, the code talkers, to win battles, to win the war. But little do people know that they also dug up the Mother Earth here and used some of the resources, uranium, to help build weapons, to help win those wars. But yet has been less cleanup in our communities. That plays a factor. And, you know, that's what we're advocating on right now, to hold our federal government accountable. But as I was saying, you know, we are in a process now to reintroduce, if you want to call it, our way of life teaching. And it gave us a full year. And I know many Navajo people took on the challenge to teach our young people about who we are as Navajo. And we assisted in one way or another by encouraging parents, grandparents to teach them. I even received a letter from a young lady that's saying, "President, thank you. I've never been this close to my parents ever because of these very strict protocols that are in place, but that help bring families together." See, I think that we are such in an era of social media that we start beginning to believe everything that we read, but most of the time it's negative. But there are positive things that are happening with this pandemic that should be mentioned too. The healing of families, resurrecting, you know, people are growing their own once again. Physically active. I think we all realize that maybe we should take better care of our our bodies and strengthen our immune system. Today, we are seeing the light at the end of the tunnel with these vaccinations. And I know not everybody agrees with the vaccination. But you know, we get vaccination as we're kids and we never question it, right? And I always say measles, mumps, and rubella, we give our kids that. And now we are in a stage where there's a virus, unseen bug here, as Navajo call it. Choshtoitini. Chosh. Tradition Choshtoitini di zegi bikijit na anish. Akonche. Zel endan linigi do and khashingego da iltragi. Huta ya. Nachayat tan kishno. You know, we tell our kids to go get an education, get their degrees and come home and help their people. And I appreciate those physicians, those healthcare professionals who have come back to Navajo, medical doctors, Dr. Tut, many other doctors here on the Navajo Nation that have presented to the Navajo people in their language as well, and to say that, you know, this is a medicine that will push back on the virus, these vaccines. And information is power. Of course, preaching to the choir here, we're talking to university professionals and college students. But if you look and step back in tribal communities, how much information government updates does our citizens get? In this time of social media, you know, you can use it as a positive tool. And that's what we've done here on Navajo. By bringing information right into the homes of our people, questions and answers given. We have folks like you all, presenters here, that are scientists and public health experts. And I thank you for being a part of the discussion here, because this information will be given to our Navajo citizens so that they are informed. You know, we have had folks like Dr. Anthony Fauci on town halls telling the Navajo people that this could be what you all are doing here on the Navajo Nation, could be a model, could be a case study for how to push back on this COVID-19 or any type of future pandemics in the United States and even in the world. Yes, we've gotten hit hard. The United States has gone through 3 waves. Let me just check the time here. Here on the Navajo Nation, we've managed to only go through 2, but we got hit hard. So we went through one less wave here on the nation. And it was because of the strict protocols we put in place. We take our sovereignty and our ability to govern ourselves very seriously, especially when it comes to protecting our Navajo people. I know people are getting antsy now, saying reopen, we need the schools to reopen, we need businesses to reopen. But is it worth one life? Life here is precious. We have over 1,000 of our Navajo people who've lost their lives to COVID-19. Our thoughts and prayers go out to their family. But I think we all recognize it could have been a lot worse if it wasn't for the healthcare professionals, you as professionals, backed by science. And of course, since we're talking about our way of life teaching, to also balance that with the Indigenous lens, looking through that viewpoint. And combining the two, I truly believe that the Navajo Nation really did their very best to not have even larger numbers that we've seen. we're at all-time lows since we have never seen these numbers lately, these 24-hour case numbers lately since last summer. And I think you can see that if we let up right around Labor Day, when the whole country started seeing the low numbers and people seeing the warm weather, wanting to get out, and look at what happened. The skyrocketing cases all across the country. We're all interconnected in some way or another. Navajo is, I always say, is like an island. Whatever happens all around us, if leaders don't take it seriously all around us, it will affect our Navajo people. And that's what we've seen. We haven't seen the Super Bowl weekend numbers, and we pray that those numbers are down, and most of these cases are from social and family gatherings, the increase in cases in our communities. So we got to stay diligent. The message is to keep doing what we're doing, to keep listening and honoring our public health professionals, our leaders in our community. And we will get through this. And that's how we've gotten through some difficult times through our history. Long walk, helping each other to get through those tough times, becoming stronger than before. And to this day, there's been vaccinations coming into the Navajo Nation, 135,000+ doses have been given to Navajo. 105,000 have been put into the arms of our Navajo people. That's 1 out of 3 of our Navajo people. We were the hot spot last year, and all this, the media attention came to the Navajo Nation, portraying us as a devastated nation or tribe. But when it comes to positive reports, not many people report on that, right? And here we're leading the nation in vaccination. We hardly hear about that. That's the media these days, especially with social media. And I'm just gonna end by saying that the importance of working together throughout these difficult times is important to our people. We appreciate the friends of the Navajo Nation who have come and assisted us during these trying times. And with the need for better infrastructure, I think was highlighted throughout this pandemic. Dr. Russell mentioned the need for water and electricity. 30 to 40% of our Navajo people don't have running water or electricity in the most powerful country in the world. If this was happening in a non-Navajo, maybe a non-tribal community, man, that would be on the news regularly. But let me just say that we are overcomers as a people, and we will get through this as we've gone through some of these difficult times. And I appreciate the presenters today. You have the ability to inspire and to encourage the Navajo citizens by your presentations. Let us not go back to saying these poor Navajos or these poor Indians, but to focus on the resilience of not just Navajo, but the 574 tribes that are still fighting for the continuation of their way of life, their culture, tradition, and their language. Yes, we've gotten hit hard by this pandemic, but we all recognize that we will overcome this public health emergency and come out stronger than before. So I wish you all a good conference. Thank you for the invitation to say a few words. I'm here to assist in any way, and I appreciate the college for what they have done to keep those numbers down and getting the message to our Navajo people in forums just like we're doing today. So God bless each and every one of you. God bless our great Navajo Nation, and take care of yourselves. Dr. Jill Jim don't hit hat sich do that so yego kodon khayaltio banana so ba here needs in kun nikhanda pa nakhalchin ni da khegi o here shinta bedi nido le kun khadi kha hada inosne bi chidi kha da here la di ni hilta halon.
Thank you very much, President Nez. We very much appreciate your attending and being here to share that message with us and to hear about the policies and directions for the Navajo Nation in these times of the pandemic. We've been extremely impressed with all of the communication that comes from the Office of the President, as well as from the Department of Health, the Navajo Department of Health, the Navajo Epidemiology Center. You can all find those websites and see that there is a lot of communication going on to the Navajo people regarding the pandemic. Just a brief review here of where we are in the agenda. So we have coming up here a keynote presentation from the Associate Director for Minority Health and Health Equity of the Centers for Disease Control. And then we'll be hearing from clinical immunology. So we'll have a little bit more of a deep dive into some of the facts about the spread of the pandemic and its effects globally. Then we'll be hearing directly from Dr. Jill Jim of the Department of Health here on Navajo about how it has been to try to build up to what we need in order to work against this infection. And then we'll hear how a group up in Canada, some of the Indian people in the urban settings of Toronto in Canada, how they're dealing with this in their situation. And then we'll have the question and answer period for all of these presentations just at noon. So that is what is coming up. And I think Dr. Lyberd is she's a very, very busy person and has scheduled her time very precisely. So we may have a little bit of time here before she gets on. And I could share a little bit with you right now about how the public health program of the Diné College has been also collaborating with the Department of Health and with the Epidemiology Center and other organizations that have come together to try to provide contact tracing. Since last summer, our public health students have actually been doing contact tracing, probably about 20 to 25 students at a time are involved in this effort. So probably as many as 40 or 50 of our students over those 6 to 7 months have participated in that effort, which has been a very intense effort that's taken a lot of emotional support and a lot of technical support to make that happen. I also know that our own faculty, Dr. Hakim and Dr. DeSoto have written scholarly publications about the virus. So the college has been very engaged in dealing with this. We've had our own incident command also that's had to institute a lot of changes. Many of our programs have gone completely virtual, and that's been a very big experience for us that will probably change instructional techniques and methodologies here for years to come. I would like to ask Dr. Hakim at this time if she'd like to say a few words about the program and how it came together, since she was the driving force that pulled this entire thing together and has pulled people together. I looked at the registration list. We have people from a number of countries around the world, principally Pakistan and India, Canada, and certainly all across the US. We have a number of people on from Alaska, although the majority of our registrants are, of course, from Arizona and secondly from New Mexico.
Thank you, Dr. Mark. Yeah, this is something like I just wanted, while we are looking forward to welcome Dr. Lyberd from CDC to join us. As Dr. Mark also mentioned, that it is kind of a very packed program, and we are trying to hope everyone be on time, and we are expecting that she will be soon joining us as she is just finishing from her another presentation at somewhere else. So in the meantime, we feel that we should tell everyone of you about a little bit with reference to this conference. We were expecting about 500 registered participants for this conference. And we were very overwhelmed that already 15 days back, we were over-occupied and all the registrations were completely filled. So then we decided to go and live stream this conference on our Facebook Live page at Diné College Facebook Live. Important thing is that most of the individuals who are registered here and who are right now looking at this conference live stream and watching this live stream, they are I just saw even we have some of the viewers from Saudi Arabia and the Middle East also, and this is something that is very important because the topic that we are trying to cover is not something that is related to only Navajo Nation. It is something that is very broad. This COVID has made all of us kind of crazy. Whether you are in advanced countries there where we have all the facilities available, or whether you are in a resource limited country where the facilities are not that much. But when you will be seeing all these different kind of data that is available, you will see that everywhere we are experiencing this virus in a totally different way. The responses from the communities are totally different. The problems and the hurdles that we are facing there, these are totally different. So how we are going to manage these, how we are tackling with this. And this is, I think that that is very right time that we are discussing all these things at this moment. So we can prepare ourselves in much better way for our future, because this is not the first time that we are having any kind of pandemic or this issue. I remember in 2003, that was the first time when I was coming to US to attend American Society for Microbiology's international general meeting in Washington, DC. And that was the exact time when the SARS-CoV-1 was spreading throughout the world. And when we reached here from Pakistan with a group of delegates and we were in the conference, we find out that the keynote speaker was not able to join us because he was coming from Canada, Toronto. And at that time, Toronto was the hub for SARS-CoV-1 infection. So this is something like, and the airports were closed, and we have to look for something new. So that is what is just like now we are experiencing with SARS-CoV-2, that all the borders and the flights and all airports, how we are dealing with this. So this global village concept, how is going to change in coming days? This is something that we also will be looking forward. So this is like this is something that is very very unique with all these issues that we are facing right now, and that we are observing right now, and then we are trying to understand with the help of all our experts in our communities here in different countries, especially those who are working in and dealing in the tribal nations. So like how we can cope up with this all, and how can we move forward, and what are the problems that we should address in future. I would also like to ask Dr. De Soto here that if he like to add some of the comments with reference to the articles and the presentations and the different opinions with reference to this COVID-19 and the Navajo Nation, that how we were able to gather some stuff and look forward. Dr. De Soto, if you are here, please share some of your points. Yeah.
Here at the Navajo Nation, I remember back in January when me and you and D. Tut started having discussions about what was happening in China and how we predicted it was going to come to the US. And then in February, before the virus came here, we had involved our president and our provost and the administration to start to prepare for the virus. And then in March, we started to outreach to the federal government, and we started to prepare to have masks and do social distancing. And me and you, Shazia, we published with Fred Boyd, I think the first paper on the pathophysiology of the COVID virus here. And yet, the federal government here was deaf. And then we continued to prepare. Navajo Nations started to reach out to the federal government. And again, deafness. And then I remember when the money started getting spent, they gave it to Harvard, to Yale, places with $1 billion in endowments. And we reached out again, and the federal government was deaf. And then the bodies started to pile up. And the international media, Japan, to India, to Europe, China, what's going on in the United States? And then our government started to do what? Started to trickle in money this way. And what we have learned from public health, from our own medicine and from our own medical practitioners, from our own leaders, is that at the end of the day, the Navajo Nation, we had to take care of ourselves. No change from the last 400 years. But as both presidents, our president, Russell, and President Nez, we did it, and we survived. And now we're doing better than the rest of the nation. And it was a collaborative effect from the people here at Navajo Nation, to our scientists, to our healthcare professionals, to our political leaders, to our medicine men, and to our elders who came together to survive against the monster. And now we're here. And we're going to continue the fight. I thank you, Shazia, for your leadership on this project. And for you, you're the one that put this together. And it was your strength of character that made this happen. Thank you.
All right. Thank you, Dr. Soto, for that further explanation. And I invite everyone to go read those articles. We now have with us our keynote address speaker. This is Dr. Leandra Lyberd. She holds degrees from University of Michigan and from North Carolina at Chapel Hill, and also from Emory University. She's quite, excuse me. She is She is the Associate Director for Minority Health and Health Equity at the Centers for Disease Control and ATSDR, Agency for Toxic Substance and Disease Registry. I always like to show that I can remember what all those letters mean. It's a complicated acronym. So in this capacity, she leads and supports a wide range of critical functions in the agency's work in minority health and health equity, women's health, and diversity. He has a critical leadership role in determining that agency's vision for health equity, which is a topic that we study with our public health students here at this college quite a bit. She has joined the COVID-19 response in May as the Chief Health Equity Officer for that response, and works to advance health equity as a priority across the entire COVID-19 response. Leads a team responsible for developing a data-driven strategy to address the disparities. She's received quite a number of honors for leadership and management and working cooperatively towards solutions in many areas. And I just want to not waste any more time and turn this over to Dr. Lyberd. And I believe we have to find her presentation and pull it up here.
Good morning, and if that's a big problem, I can certainly pull them up on this end. Just let me know. Good morning, everyone. It is my great honor and pleasure to be with you for this important meeting. I recall some years ago when I was in the Division of Diabetes Translation here at CDC, that I had the opportunity to spend a fair amount of time on the Navajo Nation as we were working to address diabetes in that community, as well as in other American Indian and Alaska Native populations. And so I'll never forget those times, the relationships that we were able to build, the many, many lessons that I learned from the Navajo people. And so it's my great honor to be here with you today. So thank you for advancing the slides for me, Dr. Bauer. So if we could go to, the first slide. As you mentioned, if you could go to the next one. Thank you very much. I wanted to just start by just saying a little bit about the Chief Health Equity Officer role and function within the CDC COVID-19 response. Last year, and certainly today, we have seen that COVID-19 has exposed decades, if not centuries, of inequities that have undermined the physical, the material, the social, and even the emotional health of particularly racial and ethnic minority populations and other population groups that are bearing a disproportionate burden of COVID-19. And CDC was aware of this almost immediately last year as we were seeing the pandemic unfold. And so to accelerate progress toward reducing COVID-19 disparities, CDC established the Chief Health Equity Officer Unit in the COVID-19 incident management structure. And this unit's sole focus is to ensure what we call an all-of-response approach to both identifying and addressing health disparities. This is also the first time in the agency's history that a senior leader was placed on the incident management leadership team with the sole focus of ensuring an all-of-response approach. And so I started last May in this role and was in it for the first 4.5 months. Then my deputy director, Dr. Jeffrey Hall, rotated in for 3 months. I came back at the beginning of the year. And our commitment, certainly on behalf of the Office of Minority Health and Health Equity, is continue to stay in this fight until we see things change. Next slide, please. I wanted to just get us started with some definitions, and this might not be necessary for this audience, but I know in all of the audiences that I speak to, there are words that we throw around that mean, we're absolutely clear what they mean, but may not necessarily be understood in the same way by the general public. So I want to talk about, first of all, what are definitions of health disparities, health equity, and then social determinants of health. So we define health disparities. It's not just the difference in health status and health outcomes between different population groups, but it's a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. Health disparities tend to adversely affect groups of people who have systematically experienced greater obstacles to health. And I think it's important that we really acknowledge that there's a patterning and that these disparities are systematic. So they are built in to many of our structures. We, though, are working to achieve health equity, which we define as when everyone has the opportunity to be as healthy as possible. And this is accomplished when we value everyone equally. When we think about social determinants of health, another term that's gotten a lot of traction over the last, I would say easily 10 years, social determinants are the conditions and the places where people live, where they learn, where they work, play, and even where they worship that affect a wide range of health and quality of life risk and outcomes. Next slide, please. And so now I want to just talk a little bit about health equity considerations. Next slide, please. When framing health disparities and discussing public health implications, it's important to use a health equity lens, such that when information is disseminated, several decisions are made regarding what to emphasize, how it is explained, and what is left unsaid. So when communicating about disparities, be sure to emphasize the value of ensuring that everyone has an equal opportunity for health and that reducing disparities contributes to the common good and benefits our entire nation. Explain that disparities can be prevented by equitable programs, policies, and services, and importantly, recommend solutions or the need to develop innovative solutions. Also consider the 3 bullets on this slide as you disseminate information. The first one is that long-standing systemic health and social inequities, including some that unfortunately have been introduced by federal, state, and local policies, have put population groups at increased risk of getting sick from some illnesses, having overall poor health, and having worse outcomes when people do get sick. A second bullet is health equity is intersectional. And so what does that mean? It means that individuals may belong to several groups that historically have experienced discrimination and therefore may have layered health and social inequities. Such intersections must be further examined so that we can better understand, better interpret, and communicate health outcomes. And the third bullet is that public health programs, policies, and practices must recognize and respect the diversity of the community they are trying to reach. And I know that this goes without saying to our audience today. Next slide, please. So we know that racial and ethnic minority groups are being disproportionately affected by COVID-19. And some of the factors that may contribute to this increased risk of getting sick and even dying from COVID-19 include things like discrimination, working conditions, healthcare access and utilization, occupation, lack of educational opportunities, and also income and wealth gaps and substandard housing. Discrimination, which includes racism, can lead to chronic and toxic stress and shapes social and economic factors that put some people from racial and ethnic minority groups at increased risk for COVID-19. Occupation plays a significant role in this pandemic. People from some racial and ethnic minority groups are disproportionately represented in what we now describe as essential work settings, such as healthcare facilities, farms, factories, grocery stores, and public transportation. And some people who work in these settings have more chances to be exposed to the virus that causes COVID-19. It's also important to consider factors that influence access to or quality of medical care during COVID-19. So inadequate health insurance, and let me ask you to go to the next slide, please, which is about medical care. Thank you. So inadequate health insurance coverage is a major barrier to medical care, and unequal distribution of coverage directly impacts health disparities. Unreliable transportation, which some people experience, also plays an integral role in persons having difficulty accessing health care, and a lack of transportation can lead patients, especially people at increased risk of severe illness from COVID-19, to miss medical appointments and potentially interrupt their ability to refill or to acquire medications. The last thing I want to mention is that the use of stigmatizing language in medical practices and limited access to culturally appropriate resources are other barriers that can contribute to reduced access to medical care. Next slide, please. And if we could go to the next slide. So why do we have a COVID-19 health equity strategy? Well, we understood early on that COVID-19 might contribute to exacerbating already existing health and social inequities. And data highlights groups at increased risk of COVID-19, including, as I've mentioned before, racial and ethnic minority populations, but also people experiencing homelessness and substance use disorder, persons with disabilities who are incarcerated or detained, and persons who are born in other countries, but are here in the US. Also, people living in rural and frontier communities, and people with age or gender-related health disparities. So effective public health intervention planning has to account for the particularities of the populations to increase the chances for success. So racial and ethnic minority populations at high risk for COVID-19 indeed face unique circumstances. And cultural and linguistic needs may determine the success or failure of a public health intervention strategy. One of the things I've been hearing about recently is how when materials are provided in English only, and the person who is receiving the guidance is English is not their first language, or they may be considered having limited English proficiency, they don't necessarily understand what the instructions are, or even necessarily that they have to come back for a second dose of the vaccine. So we have to really be sensitive as our nation is becoming increasingly more diverse, as more and more languages are spoken across the US, that we try to accommodate that in our outreach to communities as we are addressing this pandemic. Next slide, please. So as we continue, to learn more about the impact of COVID-19 on the health of different populations, immediate action is critical to reduce the growing COVID-19 disparities among the populations known to be at a disproportionate risk, those populations that I just described. And CDC's guiding principles, as we've been really focused on this work, is to reduce health disparities. That's our first guiding principle, but also to use data-driven approaches. We want to foster meaningful engagement with community institutions and diverse leaders, as well as lead a culturally responsive outreach program. And we're focused on reducing stigma, including stigma associated with race and ethnicity. So we have 4 strategic priorities to reduce the burden of COVID-19. And as you can see, our 4 priorities are listed here. And in accomplishing these, we partner with physicians, with epidemiologists, with researchers, with public health practitioners, as well as with state and local health department officials to implement the strategy. And so as we've been over the last 9 months, and we will continue in the months ahead, our 4 priority strategies are, first of all, we want to expand the evidence base in order to increase our understanding of the impact and the factors that led to the disproportionate burden of COVID-19 in racial and ethnic minority populations. We are also working to expand opportunities for testing, for contact tracing, really helping people understand what is involved in contact tracing, why people might be asking a lot of personal questions. We also have worked to increase isolation options, as well as access to care, so that we can reach, again, populations that are suffering more from COVID-19. Our third priority is to expand intervention activities to support essential and frontline workers to prevent the transmission of COVID-19. And so in addition to our healthcare workers and workers who are in long-term care facilities, we are also addressing essential and frontline workers who are in grocery stores, who work in restaurants, who work on construction sites, because again, we understand that they have very little control over their exposures to the public. And then lastly, within our response, we've sought to increase an inclusive workforce that's really equipped to assess and address the unique needs of an increasingly diverse US population. Next slide, please. So in relation to opportunities for collecting COVID-19 data on race and ethnicity, and I'll just talk a little bit in more detail about some of our strategies. The CDC Health Equity Strategy encourages the collection of data to inform the impact and factors that influence the disproportionate burden of COVID-19 in certain populations. And we are also working to support the timely and the complete representative and relevant data on testing, on incidence, on vaccination coverage, as well as severe outcomes They're detailed by race and ethnicity categories. And I'm sure you've heard a lot about even the attention of the administration on increasing our data completeness as we are attempting to address the pandemic. Next slide, please. So let's look at some numbers. Next slide. So from our case data, only half of the 20.5 million cases was available for race and ethnicity. And so from this graph on the right, you can see that white non-Hispanic populations have the highest number of cases, followed by Hispanic, Latino, Black, non-Hispanic, in the category of multiple races and other non-Hispanic, and then Asian non-Hispanic, and American Indian, Alaska Native non-Hispanic. We go to the next slide, please. And so CDC is working with states to provide more information on race ethnicity for reported cases. The percent of reported cases that include race ethnicity data is increasing. And these data that I'm sharing with you only represent the geographic areas that have contributed data on race and ethnicity. And every geographic area has a different racial and ethnic composition. And so these data are not generalizable to the entire US population, because if cases were distributed equally across racial and ethnic populations, one would expect to see more cases in those populations that are more highly represented in geographic areas that contributed data. Next slide, please. We could talk some about vaccinations. So in the 1 year since COVID-19 infections were first identified, multiple COVID-19 vaccines have been developed and put through clinical trials with the support of the US government. So far, as I think we all know, 2 have received FDA emergency use authorizations. Vaccination, again, we all understand, is a critical tool in bringing this unprecedented pandemic to an end. And so CDC continues to work with states to understand roadblocks and figure out how to overcome challenges in distribution and administration to ensure that we are getting vaccines into arms as quickly and safely as possible. And so as of February the 14th, more than 70 million COVID-19 vaccine doses have been distributed in the United States. Almost 53 million doses have been administered, including over 38 million persons initiating vaccine and 14 million persons who are now fully vaccinated. Next slide, please. So if we break vaccine distribution down by race ethnicity, we see some similar trends. So as of February 14th, with a little more than half of the race ethnicity data available for the 38 million people who have had 1 or more doses administered, we see that white non-Hispanic populations overwhelmingly have the largest amount at 63%. Compared to multiple races, other non-Hispanic groups at 14.5%, Hispanic Latino at almost 9%, Black non-Hispanic at 6%, Asian non-Hispanic at 5%, and American Indian, Alaska Native non-Hispanic at 1.7%. Next slide, please. So we see approximately the same percentages across racial and ethnic groups for those who have received 2 doses of the vaccine in the data that we have available. Next slide, please. So this leads us to what we now want to call vaccine confidence among racial and ethnic minority groups. Next slide, please. So how can we address vaccine hesitancy, which is how we were talking about it initially? Well, we address it by building vaccine confidence, which is a multifactorial concept based largely on trust. So vaccine confidence is the trust that patients, parents, or providers have in recommended vaccines. And there are a lot of community conversations going on about that. The providers who administer vaccines, and also the processes and the policies that lead to vaccine development, licensure, manufacturing, and recommendations for use. And so a person must have trust in all three of these to feel fully confident in their decision to get vaccinated. And so the foundation of trust is critical. And this is something that must be built over time. And I think all of us understand that. This is a critical concept to think about when working with patient populations who may have a history of mistrust in the medical establishment or the government. Next slide, please. So the following, and I don't know, you may have seen this, are recommendations for vaccine prioritization as we are currently experiencing limited vaccine supply. So the Advisory Committee on Immunization Practices, or the ACIP, which is an independent federal advisory committee of medical and public health experts that provides advice and guidance to the CDC director on the most effective means to prevent vaccine preventable diseases in the United States. So they've been convening for a long time, not just around COVID-19. And when they make national recommendations, we understand that there will be a level of local adaptation. So the phased vaccine recommendations are meant to be fluid and not restrictive for jurisdictions. It's also not necessary to vaccinate all individuals in one phase before initiating the next phase. So phases can overlap. So when we look at the prioritization, the US adult population is broadly divided into overlapping categories based on occupation as an essential worker, as well as age and the presence of underlying medical conditions, which we talked a lot about early in the pandemic, where underlying medical conditions like diabetes, obesity, different forms of heart disease, including hypertension, conditions like asthma and chronic obstructive pulmonary disease. These are all underlying medical conditions that can increase risk for COVID-19 infection and severe illness. So people with those conditions are part of our priority population. So in the first phase of allocation, which is phase 1A, healthcare personnel and long-term care facility residents are recommended to receive the vaccine. These groups are then followed by frontline essential workers and adults 75 years and older in phase 1B. And then next are the remaining essential workers, persons aged 65 to 74 years, and then the 16 to 64 year age group with high risk medical conditions, like I just described, are in phase 1C. And then finally, persons aged 16 to 64 without high risk medical conditions are included in phase 2. Next slide, please. So while the ACIP and CDC make national recommendations, we understand that there will be, as I said earlier, a level of local adaptation. So our guidelines are not walls or barriers between phases, but meant to support prioritizing people at high risk of exposure or high risk of severe disease. So we always anticipated that there would be overlap between vaccination phases. We also understand that the COVID-19 vaccination program is dynamic, and will require ongoing reassessment as vaccine supply and demand and COVID-19 epidemiology change to inform the timing of expansion to subsequent phases. The ACIP and CDC have endorsed the guiding principles of efficient distribution as well as jurisdictional flexibility for the vaccination program. And during a pandemic, efficient, expeditious, and equitable distribution and administration of approved vaccine is critical and within national guidelines. So state and local jurisdictions should have flexibility to administer vaccine based on local epidemiology and demand. Next slide, please. So I want to just highlight some key facts about the COVID-19 vaccine, because I know in many communities there's a huge amount of misinformation and disinformation that circles around this vaccine. So this is what we know, that getting vaccinated can help prevent getting sick with COVID-19. The vaccine works by teaching your immune system how to recognize and fight the virus that causes COVID-19. And this protects you from getting sick with COVID-19. Secondly, people who have gotten sick with COVID-19 may still benefit from getting vaccinated. And I know that was a rumor, a misinformation floating that you didn't need the vaccination if you had already had COVID. But due to the severe health risk associated with COVID-19 and the fact that reinfection with COVID-19 is possible, unfortunately, the vaccine should be offered to you regardless of whether you already had a COVID-19 infection. And also at this time, experts don't know how long someone is protected from getting sick again after recovering from COVID-19. Thirdly, COVID-19 vaccines will not give you COVID-19. I want to say that again. The vaccine will not give you COVID-19. So why? None of the authorized and recommended COVID-19 vaccines or COVID-19 vaccines currently in development in the US contain the live virus that causes COVID-19. None of them contain a live virus. So this means that a COVID-19 vaccine cannot make you sick. And then fourthly, COVID-19 vaccines will not cause you to test positive on a COVID-19 viral test. So neither the recently authorized and recommended vaccines nor the other COVID-19 vaccines currently in clinical trials in the United States can cause you to test positive on viral tests, which are used to see if you have a current infection. If your body develops an immune response, which is the goal of vaccination, there is a possibility you may test positive on some antibody tests, but not on the viral test. Antibody tests indicate you had a previous infection and that you may have some level of protection against the virus. And experts are currently looking at how COVID-19 vaccination may affect antibody testing results. So we're still examining that. Next slide, please. So COVID-19 vaccination will be an important tool to help stop the pandemic, but it continues to be just one tool. There's the things that we want you to continue to do. So while these mRNA vaccines or messenger RNA vaccines appear to be highly effective, additional preventive tools remain important to limit the spread of COVID-19. So the combination of getting vaccinated and then following CDC's recommendations to protect yourself and others will offer the best protection from COVID-19. So what are these? We've heard them multiple times. Cover your nose and mouth with a mask. Stay at least 6 feet away from others. avoid crowds, avoid poorly ventilated spaces, and wash your hands often. So stopping the pandemic is going to require that we use all the tools that we have available. And it will take time to vaccinate all people living in the United States. And while the vaccines are being delivered, it's important that everyone continue to take all the steps that I just named to prevent the spread of COVID-19. So next slide, please. So again, just to reiterate how to protect yourself, your family, your friends, your coworkers, and your community. We know that the vaccine can protect you. We want you to choose to get vaccinated. And we want you to participate in VSafe, which is a program that was developed by CDC, and it works in smartphones. And this in VSafe helps CDC monitor for any health effects after vaccination. We also want you to share your experience with your coworkers, your friends, and your family. And if we have time later, I'll share a story with my hair stylist where she's been really boasting about having gotten the vaccine. And also visibly show that you received the vaccine by wearing a sticker or a button, if that's available. And again, I just want to reiterate that we all have a role in increasing confidence in the COVID-19 vaccine. And as we share our experience with others, it helps them to have more confidence in it as well. Next slide, please. And I am winding up. What is CDC doing in addition to what I've shared? Next slide, please. You know, we are providing assistance to public health agencies and others to expand testing, contact tracing, and isolation options in medical care. We're facilitating partnerships between public health agencies, tribes, scientific researchers, professional organizations, and community members. We understand it's going to take all of us to really bring this pandemic to an end, and all of us working together. We're also offering technical assistance to local communities that are experiencing the COVID-19 outbreak. And also where there are essential workers, like people who work in meat processing plants or in agriculture or in nursing homes. And we're supporting essential and frontline workers to prevent the spread of COVID-19 in critical workplaces. We're developing guidance to implement programs and practices that are in different languages and are culturally tailored to diverse populations. I think the last time I inquired about how many different languages we had prevention materials in, it was over 60. So I'm really excited about the work that our translation group is doing here at CDC. And we're continuing to build an inclusive public health workforce that's equipped to understand and meet the unique needs of our nation. And then lastly, we're continuing to collect data to assess and track disparities related to COVID-19. Next slide, please. And just to, I think, bring it home in terms of an example of the work that CDC is doing with states, tribes, local and territorial health departments. This activity is what we call the Navajo Nation WASH. And it was established to improve access to potable water service for residents of Navajo Nation in order to increase the ability to perform the COVID-19 prevention activities like hand washing, which was very big and continues to be an important mitigation strategy. And you can see what happened in the description. And you can also see that we're very pleased that we can document some early impact from this activity where there has been increased access to potable water sources, and there's been a decreased average round trip travel distance to obtain water from 52 to 17 miles. Next slide, please. So I just want these next few slides will just show you resources that are available on our website. And I encourage you to visit the COVID-19 website. If you could go to the next slide. And there's another activity called FACT, which is facilitating acceptance with community-based trusted messengers. That's another activity where our vaccine task force is working, increasing its outreach and partnership with community-based organizations, with community health workers, and with faith-based organizations so that we can be part of providing community education and equipping them who are the trusted messengers with carrying those messages forward. Next slide, please. We've been done a number of listening sessions, which have been incredibly insightful for those of us who are in Atlanta or in other parts of CDC, so that we can better understand what's going on in communities on the ground, so that our response can be tailored and therefore kind of more effective. Next slide, please. So as I said earlier, CDC alone, public health alone, healthcare alone, we will not be able to end this pandemic without working with community and faith-based organizations, with employers, with healthcare delivery systems, and also with state, tribal, local, and territorial governments. Next slide, please. Here are more resources. Again, you know, a lot of times we get feedback from the states in particular about what are our examples of what other states are doing, and you know, what are some toolkits that we can use. And so these are some of the resources that are available right now, and we are continuing to add more toolkits and resources as we are able to. Next slide, please. Well, thank you very much. I know that was a lot of information. I hope it was informative. And thank you again for the opportunity to be part of this conference. And I hope to be back later in the day to take questions. Thank you so much.
Thank you, Dr. Leandris, for that marvelous presentation of all the different things that CDC is considering in working towards health equity. We do have a few questions that have developed in the question and answer function here. If you have a few minutes yet, probably answer a few of them before you go. Would you have time?
Sure, yeah, absolutely.
Okay. There's a question from Christina Morris, who is a colleague of mine who works in the New Mexico State Health Department. She asks, I have always understood that social determinants of health are more than conditions, that they also constitute the social constructs and mechanisms that mobilize disparities. Will you discuss how CDC is working toward interrupting and dismantling systems that perpetuate harms in community health outcomes?
Yeah, no, you're exactly right. I mean, I think, let me say that the definition that I shared from social determinants of health comes from the work that we did with Healthy People 2020 in standing up the first social determinants of health topic area. And we're very proud of that work. And we also talk about it as being place-based, which is also, I think, consistent with your acknowledgement of social constructs and mechanisms. I think some of the mechanisms that in fact mobilize disparities were some that I mentioned early on. not the least of which are issues around discrimination and racism, which we know are systemic. And so how are we working to really dismantle and interrupt those systems is that we have launched and are in a very aggressive, or I should say accelerated movement around really building more expertise within CDC around both health equity as a practice as well as a science. And by definition, that takes us beyond our focus on individuals and into a focus on the social environment. We're doing a lot of things internally around looking at how we structure our notices of funding opportunity announcements and how we can better integrate opportunities to address health equity and more of the factors that you're raising. We're also, starting our own work around looking at and adding to the literature around racism and public health, and again, how we can address that. And we recognize that all of this work and our ability to dismantle, again, like with everything I shared earlier, will only come when we're able to partner with multiple sectors. Because again, public health is but one part of a much larger system. So I'm, thinking in the days ahead that we'll be able to add more partners, be able to really examine and explore these issues in a more systematic way that can then be engaged in public health practice, as well as expanding our portfolio in public health research to address some of these structural barriers.
Well, it was a long and deep question, and thank you for
a long and deep answer.
Yes, these are very complicated issues.
They are.
We had another question from Eva Bighorse, and she wanted to know whether your data on COVID deaths and vaccine administration include Indian Health Service 638 state.
It includes data from state health departments, and their data, some of it comes from the labs. I'm not aware about the inclusion of IHS data in the data that I have presented. I can follow up to see if IHS data is included. And 638, I would need to, I can follow up on those two as well.
Okay. Maybe one more question. We have one from Ambria Tolino, who is one of our Diné College staff and students. Dr. Leanders, in regards to data among American Indian Alaska Natives vaccination distribution, sorry, my little box got cut off here for a second. I have to move it. It's frustrating. Couldn't quite see the, there we go, excuse me. He wonders if data among American Indian Alaska Natives vaccination distribution are situations such as healthcare worker availability and healthcare facilities and healthcare needs to store and distribute the vaccine. Do those pose contributing factors in explaining that data in the community?
I can't answer that question. I don't know. I don't know the answer to that question. What I know is that from where we are at the CDC level, we're working very, very closely with FEMA, which is they're setting up a number of sites around the country to increase access to the vaccine. We're working very closely with the White House to ensure the equitable distribution of the vaccine. And so I can't speak directly to, at this moment, to what is going on in the American Indian Alaska Native population in terms of why there is this lower coverage that I shared in the data.
Yeah. All right. I think we will save the rest of the questions for the question and answer at the end of the morning.
Okay. Thank you very much.
All right. Thank you. Now that we've spent some time talking about the CDC and the response in this country, we're going to move to the next speaker and be talking about the global situation and diving a little deeper into that data. So I would like at this time to introduce Dr. Stephen Spector, who has degrees in biology and microbiology and immunology from Temple University. Has worked at a number of different institutions, the Albert Einstein Medical Center, University of South Florida College of Medicine, a number of different positions in faculty and in being associate deans in different areas. He established the annual Clinical Virology Symposium in 1985 and continues to chair this. It's an internationally renowned conference. He's president of the Florida branch of the American Society for Microbiology, so he represents our sponsoring agency here. He's been on numerous journal editorial boards, professional councils, and his research is in the fields of retrovirus-induced immune deficiency and effects of abused drugs on the immune system. Author of more than 175 scientific publications, review articles, book chapters, many awards, and is currently membership chair for the American Society for Microbiology. So Dr. Spector.
Thank you, Mark. I'm going to try and share my screen from here if I can.
I believe, yeah, should be able to.
But that did. Hopefully, well, I just went blank, so I'm not sure what's happening.
Okay, there we go. We're starting to.
Yeah, just loading slowly, I guess. That's not me. Huh.
It said Dr. Stephen was starting to.
Yeah, I'll try again. No, it's apparently not going to let me do it, so maybe you need to do it.
Dr. Hakim, do you have his handy?
Let's try again. Let's try it again. I'm trying again. Let's see. There we go. Okay. Well, I'll start by thanking Dr. Hakim for inviting me to give this presentation and the opportunity to talk about the global scenario related to COVID-19 and the historical perspective of all this. And you can see the picture of the virus here. And I think it's important to point out where the name comes from. And so in the mid-1970s, a virologist by the name of June Almeida was the first to visualize this virus with the electron microscope. And she was impressed by the fact that this virus particle looked a lot like the sun with its corona, and that the spike proteins that you've heard so much about actually look like a crown around the virus. And so she decided to call this a coronavirus, and that's how it got its name originally. And we can look at how this relates to other coronaviruses when we begin to talk about SARS-CoV-2, the virus that causes COVID-19. And if you look at the genetic map here, you can see with the blue star where SARS-CoV was the original SARS virus that arose almost 2 decades ago, and then SARS-CoV-2. And you can see that these viruses are pretty closely related. What you're looking at are variant SARS-CoV mutants that arose from the original SARS and now SARS-CoV-2. And the point I want to make is the closer the viruses are on this map, the closer they are genetically. So if you go way down to the bottom of this map, you see 4 viruses that are HCoV, and that stands for human coronavirus. These are the typical coronaviruses that cause common colds in humans. And you can see they're quite genetically distinct from the SARS-CoV-2, but the viruses that are much closer are bat coronaviruses. And so you may have heard already that this virus seems to be derived from a bat coronavirus that somehow passed through some other host before it got to humans. And the related viruses, the SARS-CoV went through a cat called a civet, and then the MERS-CoV, which arose in 2012, is related to having gone through camels before getting to humans. So this is the genetic relationships we're talking about. Now, you've heard a lot in the last month or so about mutants arising from SARS-CoV-2 and whether they're going to be more problematic or not. They seem to be more easily transmissible. And if you were to look at them on a map, they would fall right in this little area right where SARS-CoV-2 is. So they're very closely related because they're just simple mutants from this virus. One of the important things to know about RNA viruses especially is they mutate relatively easily. And in doing so, they tend to move toward a more transmissible virus because they're trying to survive. And we call this phenomenon viral fitness. And viral fitness predicts that a virus will tend actually to become less pathogenic, cause less severe disease as it mutates. Now, we haven't really seen any evidence of that with these new mutations, and even some suggestion that they might be a little bit worse. And I think one of the important things to take note of is that this SARS-CoV-2 has not behaved at all like other coronaviruses, in that it has not been seasonal like they typically are. And it has also not behaved by like most respiratory viruses that tend to have a defined season. So when we try to predict what's happening, and you heard Dr. Fauci say, some of the things they said in the early days of the pandemic were just flat out wrong because they were making predictions based on normal respiratory virus behavior. And this virus is anything but typical. So that has really caused a lot of consternation in causing differences. So this brings us to the outbreak that we're referring to when we talk about this pandemic. And you can see that the very first cases occurred in early December of 2019, and that was in China. And you really did not have confirmation of cases until late January. And the yellow bars you see are actually confirmed cases of this. And so we began to see a relatively large number of cases occurring in Wuhan province in China, especially associated around Hunan. And they believe that the Hunan seafood market may have been the site of where this virus actually originated. And China has had a history of these live animal markets leading to severe epidemics of disease. It happens with influenza on a number of occasions. It happened with the original SARS virus. So this is where things all began. And this next picture is a very telling picture, I think. And it really tells you why the Chinese were successful in slowing their epidemic. What you're seeing here is a satellite picture of China, especially up in Wuhan. And the area you're here seeing is lights, just electric power being read by infrared sensors from space. And this was on during the first 3 weeks of January. Then China went into a lockdown. And look at what you see now. You see almost none of this activity. People were at home and businesses were shut down. And I think this tells you an awful lot about the conscious distinction between China, where the epidemic was not nearly so bad, and the US, where the number of cases are by far the worst in the world. And there are two things that we can use to explain this. Number one is in China, we have a communist government that is authoritarian and very distinctly put out orders to shut down this area of the country. The other factor is that being raised in a communist country, the people in China listen when they're told to stay at home and lock down. By contrast, in the US, we did not have a definitive message coming from our governmental leadership. And we know, going way back to the time of the revolution, that Americans have a very distinct way of doing what they want and not necessarily listening to orders. And so we all know that mask wearing and hand washing and social distancing have not been adopted by all Americans. And this has caused a lot of the problems that have set us apart. And we'll see some of the numbers with that shortly. So this is looking very early on after the 100th case was recorded in the world. So we're going way back to January of 2020. And we can see the trajectory here. And if we look at the bottom, we see Singapore, Hong Kong, Japan, South Korea. And we're seeing that these Asian countries were much better at controlling the outbreak and still have been somewhat better. On the other hand, the Western countries are where we saw the biggest problems. And even way back in March, when we were just beginning to get cases emerging in the US, they were beginning to emerge more rapidly than anywhere else. So this is the early tip of the iceberg. But this trajectory continued for these countries up through today, really. You can see the original outbreak that occurred here in China. It spread to neighboring areas, which then spread to the Middle East and to Europe in substantial numbers. And then finally over to North America, where US, Canada, and Mexico began to show cases. Very little as of March in Brazil, but we know that Brazil became one of the epicenters and the major epicenter in South America. So we could see this evolving across the world. And here's another map showing the spread, and you can see from very specific places, this virus was able to spread everywhere. And obviously air travel is a big factor that affected this. Again, these are data that go back to March and April of 2020. And so if you were to look at this today, these lines would be much thicker and stronger because the spread has increased, although international spread has been somewhat limited because of the limitation of international air travel. So this brings us to today and the actual numbers we're looking at. And this is literally as of this Wednesday. And we can see worldwide there are 110,000 cases. Million cases. And 28 million of those were in the United States. So you can see that almost 25% of all cases have occurred in the US. I'm sorry that this is blocked here, but the same is true for the number of deaths, nearly 500,000 deaths in the US as of the other day. Again, this represents approximately 25% of all of those that have occurred in the world. And again, this has to do with our not limiting the spread of the virus in this country through the behavior of many individuals. We can see that India is second. As you go down, you can see great diversity. One of the ones that I want to point out most obviously here is the Czech Republic, or Czechia. You can see about 1 million cases here, and you'll see in a subsequent slide, this is actually the worst part of the pandemic. While the numbers don't look that large, the population is not that large, and per million population, it's the highest incidence in the world. And so if we look at this, I kind of titled this The Good, the Bad, and the Ugly. We have a couple of countries here that I called the good. If you look at Thailand, they've had 21,000 cases, which translates to 304 per million population. And they've only had 79 deaths, or 1 per million population. So these are actually the best numbers in terms of per population. On the other hand, if you look at New Zealand has had 2,308 cases. And although that's slightly higher per million population, it is the smallest number of cases in a Western type country with only 5 deaths per million population. So these are examples of where the virus has not spread very strongly. New Zealand, obviously, a lot of that is due to the fact that it's an island nation. It's easy to isolate there. If you heard on the news this week, there were 3 cases that occurred in one family this week in Auckland, and the entire city of Auckland was shut down for a week to prevent the spread from this family. So they've taken extreme measures, and that's why I put them in the good category. In the bad category, I list the US. At the time that I made this slide up, there were 27 million cases for a number of 81,413 per million population. Not the worst in the world, but one of them, 458,000 deaths. As you saw on the other slide, we're up to 500,000 now, which translates to 1,381 per million population. United Kingdom has one of the highest numbers in numbers of deaths. Even though the number of cases are lower than the US, the number of deaths per million population is substantially higher. And then the very worst are Belgium, which has had 61,000 cases, but more importantly, 1,822 deaths per million population. That is the highest incidence in the world of deaths. And then Czechia, which has had the highest incidence of number of cases per million population at 93,618. So very large spread in these countries. And obviously not a strong public health program able to stop that spread. If we look worldwide at the daily numbers of new cases, we can see this great surge that occurred after the Christmas holidays, as was predicted. And then the good news is that worldwide, this number is decreasing. And if you look at the peak here in early January, you can see that the number of cases per day now is only half of what it was at that peak. So this is very good news. I think this is a combination of, with more people having been infected, there's less targets. With people getting vaccinated, there's less targets. And so all of this is playing into helping reduce this. Plus people are behaving a little bit better now. And all of this has worked to improve the situation. However, we're still talking about 350,000 cases a day worldwide. So there's still a substantial problem, even though things are getting better. If we look at deaths, the same picture. One of the key things that is important to know about deaths is if you were to compare this graph with the last one, you would see that there's about a 2 to 3 week lag in the number of deaths compared to the number of cases. And that's simply because once someone gets sick, it takes a while till they get acutely ill and then pass away. But even in this particular case, we are seeing things coming down now. If you were to look at the graphs of just the US, they would look identical to this. And one of the really good pieces of news is You know, if you were to look at the data from yesterday, you can see that the numbers are still fairly low. We are now 12 days post Super Bowl, and we are not seeing a surge that we might have expected. We still may see a slight increase in cases, but I don't think we're going to see the great surge that people worried about. As a disclaimer, I will tell you, I do live in Tampa. I went nowhere near these celebrations that took place with lots of people not wearing masks or social distancing. And I hope those people were lucky and we don't see a surge, but that's a real issue. Looking at the data from the United States, you can see that California has the largest number of cases. Florida's at number 3. If you go down, Arizona, where many of you are, is at number 10. And I put the bottom of the list here, and we see the Navajo Nation, and you can see the number of cases here is 29,200 as of the middle of this week. So what you heard about a little earlier, that while there may have been a major problem early, this has been controlled better through the Navajo Nation than pretty much anywhere else in the United States. And I wanted to take a look at indigenous populations worldwide, because while we've heard a lot about the Navajo Nation and First People populations in North America, this is a problem everywhere. And what I found when I went to look up information about indigenous people and COVID was there is not good information out there that is accurate. And what I found looking at different websites is that the estimates worldwide of individuals who would fall into indigenous populations range from a little more than 300 million to over 500 million. That's a huge disparity, meaning the data are not very good, which is a big problem with trying to get this under control. We find them in both urban and rural locales. There are identified indigenous populations in 90 countries worldwide. And overall, depending on which of these two figures you use, they range anywhere from about 4 to 6.2% of the global population. The disturbing statistic is that there's nearly 3 times as likely for these individuals to be living in extreme poverty and thus have more infectious diseases, but not just more infectious diseases, but prone to more severe infectious diseases because they don't have the access to care that they need. And when I was looking at many of the websites that I looked at, I did not find a single one outside of the US that provided any reliable data on COVID-19 incidence or prevalence in indigenous populations. So I found that very disappointing. And actually, as I looked, I noted more than 167 listings on Google of indigenous peoples and the COVID-19 pandemic. These are actually postings or articles that exist. One of the most disturbing was the fact that there was an article in the US that talked about the erasure of indigenous people in the COVID-19 database. So the numbers that we are getting, we have to question how valid they are because they're not being represented well. And then all these other titles that you see here are just different articles. And I wanted to make a point that you can see articles on North America, Native Americans, Mexico, South America, Brazil, Peru, Asia, articles there, Bangladesh and India as well, and then in Africa. So literally, as you look across indigenous populations on all of the continents, you can find people looking into this and addressing it, but yet still we're not able to get strong data to understand exactly what's going on in these indigenous populations. Hopefully that will resolve in time, but I'm not optimistic that that will happen. If we look in the US, I noted that amongst the Navajo Nation, and I'm not going to try to pronounce this because I'm sure I would butcher it, but COVID-19 has been referred to in the language of the Diné as the cough that kills. And if we look in Arizona, the Native American population is 4.5% of the population and represents 5% of the COVID cases currently. And so this is pretty consistent with what you'd expect in a population. So while early on there may have been an excess number of cases, currently it looks to have normalized well. And I think we can attribute that to the health service amongst the Navajo Nation and the work that they've been doing to mitigate this. And you already heard about what a great job they're doing with vaccination. In New Mexico, very disparate data here. Native Americans constitute 11% of the population. One paper said that represents 57% of the COVID cases and 50% of the deaths. And here's the reference I got that from. However, on a second site, which is the official COVID dashboard by the state of New Mexico, it only says that 16.3% of the cases are Native Americans. So I can honestly tell you, I'm not sure what is accurate or what is close, but very clearly there's a big disparity in people's understanding of what's going on. In Oklahoma, where the Native American population is 9.3%, 13% of the COVID cases are in that population. And so there does seem to be a somewhat higher number of cases, but it does not appear to be alarmingly higher as this earlier report in New Mexico would have suggested. If we look at cases per population, and I want to focus on cases per million, when I collected the data, it said in the US, there were 85,743 cases per million. In the state of Arizona, that was much higher because it's been an epicenter. And in the Navajo Nation, a little bit less than the Arizona population in general, but higher on the percentage basis than the US. But when you look at the number of cases per million population, it comes out almost identical to what you see across the US. Now you notice I put an asterisk and said this is estimated. And the reason I did that is because finding a real current number for members of the Navajo Nation is very difficult. The only population statistic I was able to find was from the 2010 census. And I suspect there's been some change since 2010. And when we do get the 2020 census, we'll have a much more accurate number there. But this was the best I was able to show you on what's going on in that population. So one quick point about the virus and things you've heard about it causing disease. The virus binds to the ACE2 receptor. And in individuals who have lower numbers of ACE2 receptors, they actually are at higher risk for developing serious disease with COVID-19. And so this is something that needs to be investigated further to look at different ethnic groups and see if there are disparities in ethnic groups of expression of the ACE2 receptors. And I did see one paper that was presented that suggested that in African-American populations, that this higher ACE2 phenotype actually was prevalent and may contribute to the higher number we're seeing in African-American populations, in addition to the disparities you've already heard about. So what can we do about COVID? Well, the first thing we heard about were therapeutics. We had antivirals, and the first one that came into use was remdesivir. This is a nucleotide antagonist. It has some beneficial effect, but not as much as we would like. It is only used in the most severe cases. There are other antiviral drugs that are still experimental and in development, but we may see them come into play. We've seen the use of anti-inflammatory drugs, most notably dexamethasone, which is a corticosteroid that cuts down inflammation. And we know that in many severe cases, it is the inflammation that is causing damage to the patient. We are aware that recovered patients have been harvested for their plasma, which contains antibodies against the virus. And then we know that there has been the development by a couple of companies, one of which the president was treated with, of these monoclonal antibodies against the spike protein. And so these various treatments are available, but there's no standard of care yet with them because not enough experience to really tell what's the best combination. And I threw the anti-parasitic drugs in here because they have been in the news. Hydroxychloroquine was promoted by President Trump, was subsequently shown to be ineffective. This was an anti-malarial drug, and I'm hoping we don't hear any more about that. And more recently as 2 weeks ago, I heard a similar suggestion that ivermectin might be used. This is again an anti-malarial drug, and to date, there have been no sophisticated studies to show whether there's efficacy or not. This is remdesivir. I think one of the interesting things you should know about this is an analog of adenosine. So it's like a natural product, but it blocks the elongation of the viral RNA. And the interesting thing is that the drug itself is not effective. When it is ingested by or injected into the individual, it then is metabolized by the body into the active metabolite, which then goes and blocks the enzyme that allows the virus to replicate. So an interesting principle that a lot of people don't know about is the idea that very often we use prodrugs that then get metabolized into the active form and can be very useful in preventing disease. And then the last major topic is the Operation Warp Speed that you've heard so much about, and the 5 candidates that were utilized for this. The first 2, Moderna's vaccine and the Pfizer vaccine, are messenger RNAs. They are both now 2-dose regimens. This is an old slide, but today we know they're in clinical use and shown to be highly effective. The Merck Sharp and Dome was withdrawn, so that is not in use now. Johnson & Johnson vaccine was just approved for use. It is a single dose vaccination. It is in human adenovirus vector. And so that is just beginning to be used. And we'll see a lot more of that coming into use in the US. And then finally, the AstraZeneca vaccine, which is in use in much of Europe now and is shown to be effective with 1 shot. There was mention a little while ago of whether or not vaccines should be used in individuals that have already had COVID-19 and how beneficial they would be. I had the good fortune of being asked to review a manuscript submitted to a journal just this week. And there was a clear indication that 1 vaccine dose of the Pfizer vaccine to individuals that had COVID disease very strongly boosted their immune response to a level that was about 4 times what is deemed to be the minimally effective level at neutralizing the virus. So that's important. Another point I want to make about the vaccine is to comment that the vaccine prevents illness. It does not prevent infection. All vaccines are designed to prevent disease, but you may still get infected. It's just that your immune system cuts off development of disease. So this idea that people could be vaccinated and could carry the virus and transmit it to others is something that could happen, but there's a short window for that to happen from the time the person is exposed to the virus until their body clears it. So just wanted to clarify that for you. And that is my presentation. And if there's time, I'll be glad to answer any questions.
Dr. Spector, this is Dr. Desoto. I had a question. I noticed that there's a large differences in the death rates going country to country. And I'm not getting a good correlation based on economics. So what's going on with that?
You know, it's very difficult to make that determination. I don't think it's just economics. I think it is related to quality of care. and the procedures that are used from one locale to another. And I'll give you a good example. If you look at Florida and my neighborhood, if you look in Hillsborough County where Tampa is, the number of deaths is about equivalent to what you see in Pinellas County where St. Petersburg is. But the number of cases in Tampa is about 80% higher, meaning the death rate per infected individual is much lower in Tampa than it is in St. Petersburg. And I don't believe there's much of a difference in terms of quality of care. And so what I'm suspecting is in St. Petersburg, which is a beach community with many more senior citizens, that what we saw was a problem with individuals getting infected in nursing homes, and that the most compromised individuals are the ones that are dying more frequently. And that may be true worldwide, but it also may have to do with quality of care from one locale to another. And I just can't tell you why that's happening. I mean, if you look at very poor countries, you could understand why that might be the case, because they don't have the resources with drugs to support patients. But it's happening in westernized countries at different rates as well. If you look at a country like the United Kingdom, very clearly, they have all the wherewithal to do a good job, and yet they have a high mortality rate. And it's really not clear why that's happening.
Okay, I think we had a couple of questions that came in the question and answer from our attendees. Here's one from William Folk. While genetic polymorphisms in ACE2 may account for some differences, what is clearly much more important are the consequences of diabetes, cardiovascular, pulmonary problems that are exceptionally high in Native Americans.
Yes, I mean, very, very clearly, any kind of underlying disease, and all the ones you mentioned there, clearly qualify for that. And part of that may actually be related to the ACE2, because you can find ACE2 receptors in all of the tissues involved in pulmonary cardiovascular and diabetes organs. So, you know, it may be that there's some relationship there to what's going on with those diseases and the ACE2 receptor, or it may just be that individuals' immune system are compromised by the fact that they have these underlying diseases. So that may be a problem. I see another question. Somebody asked, how long is the vaccine effective after receiving the second dose? And I can promise you that no one can give you the answer to that, because we have not had enough people long enough after the second dose to check to see how badly antibody levels have waned. And so that's a question that probably shouldn't be answered. We should be looking at 3 months, 6 months, a year, maybe even longer, at whether immunity is remaining effectively high or not in those populations, but we're not that far out yet. So we have to wait to collect those data. My suspicion is that we will have enough residual immunity to, at the very worst, mitigate illness if one should become infected with the virus and develop disease. I would expect that the immune system would kick in. We do have what are called memory cells in our immune system. They circulate in the body and they get turned on as soon as we encounter something we've seen in the past, and they give us a secondary response that will help us. So I've got to hope that that is going to be the case. Another question was, any data about long-lasting COVID on minority populations? I'd like to know if there's similar disparities in incidence or if that is even being collected. I don't have the answer to that. I suspect that we don't have good data yet. And my hope would be that because we heard from the CDC, that they are indeed going to be collecting those data and be able to give us some good answers about that, but I expect that's a ways off.
You're doing a nice job doing your own moderating here. Continue if you want.
Okay, so with the 5% cases in the Navajo population in Arizona be due to a larger number of COVID cases in Arizona than in New Mexico, it could be. There may be, well, there certainly are more population centers, 2 major population centers in Arizona that don't exist in New Mexico. And that certainly is probably as much to do with it as just the larger number of cases in Arizona, because you tend to have larger number of cases in urban populations where people are much closer together, or even potentially on a reservation where people tend to gather within their own group. So I would suspect that it's related to concentration of people, not just larger numbers. And I think that's all the questions I see that were directed at, well, maybe not, let's see.
Steven, this is
I do not know much about the populations of individuals who volunteered to take the vaccine. So I can't really, I can only tell you they were between 18 and 65 years of age, but not anything more than that.
Okay, well, I believe we can probably handle any other questions in the question and answer period.
Sounds good.
But thank you very much for providing that level of detail for us about the virus itself and its spread and the rates over time globally. That's been very interesting.
Thank you.
And the comparisons with Navajo Nation, where you could do them, were also illuminating. And on that note, we'll turn to Dr. Jill Jim, who is going to talk to us about the situation on Navajo Nation. Dr. Jim has recently been on President Joe Biden's transition team as on his COVID-19 advisory board. She's been our director of the Department of Public Health on Navajo for several years now, and has been, she's been executive director since 2019.
Yeah, I'm just.
Okay, sorry, that was a small interruption there. She has her doctorate in public health and a master's degree in healthcare administration and in public health, and a bachelor's in health promotion and community health education. And she's had a lot of work experience in addition to being at the Department of Health in healthcare analysis for Health Insight in Albuquerque and consultant for the Indian Health Service, and also worked with the Utah Department of Health. So I will turn this over to my esteemed colleague, Dr. Jill Jim.
Yes, Dr. Bauer, thank you for that introduction, and always a pleasure to contribute to this the conversation that's going on today, and also have enjoyed listening to others present today as well. And I'm Dr. Jill Jim, as you mentioned. I'm the current Executive Director of Navajo Department of Health, and I do have a presentation to share. So if I could share my screen, I think I can begin with that, and then if you guys can see my screen, just let me know.
Hello, this is Michelle with the IT department. We need to reconnect to Facebook Live. So I believe Dr. Steven, can you give us the host to either Shazia or myself?
Okay. Yes, sorry, Dr. Jim, if you could give us a moment here. Hopefully they'll let us know when this has been accomplished.
I have something that popped up that shows that all panelists should be able to share.
Dr. Steven, at the right corner of my screen, There are 3 dots. If you can click there.
Okay.
If you click there, then just you can make me host. So
Yes, I did.
yes,
You should
please.
have it now.
Yep. Thank you very much.
Okay.
Okay, can you let us know when Dr. Jim should continue?
Yes, Dr. Jim, you can start now, please. Thank you very much for this, and sorry for this interruption.
Shazia, I'm sorry, it's still, okay, it's on now. Thank you.
Okay. Dr. Bauer, can you see my screen?
Yes, it's looking good.
Well, thank you everyone again. Like I mentioned, I am the current executive director of the Navajo Department of Health and also a former member of the Biden-Harris advisory team, and definitely have been honored to serve in that role during the transition time as well. And my daily role here at with the Navajo Nation is also helping and coordinating and facilitating the response to the pandemic as well. So I was privileged enough today to provide an update on facilities and capacity to combat COVID-19 like situations in Navajo communities is the topic I'll be covering today. And I just wanted to just start out with just some coverage of just the overall pandemic response here in Navajo Nation. I always like to just remind or reflect on how we are have the ability here in the Navajo Nation to institute our own emergency response. Recently, we were able to achieve getting a disaster declaration through with tribal leadership support and everyone else to have President Biden support that for the Navajo Nation as well. Our first public health emergency response was initiated on March 11, 2021, and the Commission on Emergency Management declared this emergency at the time when COVID-19 was coming here to the United States as well. And also that the Navajo Department of Health at that time was also authorized and has been established to respond to the emergency and coordinate that response. And in response to that, we created a unified command group mid last year, and that was a coordinated effort. And I'll kind of get into the detail of how facilities and other areas of the Navajo Nation are responding. Whoops, let me go ahead and go back one here. So I always like to refer to the Navajo Nation as a unique Navajo healthcare system. We are very much a mixed healthcare system here on the Navajo Nation, and I think that is always a reminder. Some tribes do have the ability to have a single oversight of healthcare hospitals, but we don't, not on Navajo. We have several tribal health organizations that we identify as self-determination contractors or self-governance compactors, and the tribe has authorized these health facilities to provide healthcare services on behalf of the Navajo Nation. So they're no longer federal health facilities, but they are also responding and on behalf of the Navajo Nation and their local communities. And you'll see the map on the right side that does demonstrate partially some of those facilities, but there is still some areas that you won't see, like Utah Navajo Health System. And then there are 5 federal service units as well on the Navajo Nation, which is Kayenta, Chinle, Shiprock, and Gallup and Crown Point are the 5 federal service units, which are services provided by the Indian Health Service. And then there's one urban Indian health center as well. In the far right, in the New Mexico, we also identify these smaller communities as satellite clinics in the state of New Mexico. And so I always like to say that for the Navajo healthcare system, it is a mixed healthcare system, and you can equate tribal health organization as something like private health organizations outside the Navajo Nation as well. And we are a very large land base, and you can also see that we are in the state of Utah, New Mexico, and Arizona. And I think you can kind of imagine the type of relationships and collaborations we have to have in order to respond and work with not only state and federal and county entities. We stretch around 27,000 square miles and larger than some states in the United States. And I always say, if we were a 51st state, we would be in this situation. So we do monitor how we compare to states in the United States using some basic measures through our epidemiology and surveillance effort. And as you know, I mean, there are some factors that we will consider. And right now, the population numbers that I'm showing here are Navajo Nation residents. I know my colleague and the Navajo Epidemiology Center is under the Navajo Department of Health, and they work with all of our federal and tribal health organizations to identify cases every single day. And some numbers will be different. In 2016, you could say there's, based on census numbers, there was about 173,667 individuals that lived on the Navajo Nation. So these numbers here reflect only Navajo Nation residents and not border town residents. So those are the different numbers and reporting systems that we do have. But every day, the collaboration that we have is we get information from all of these health facilities in order to make this happen. And there maybe has been a day or so that we were delayed, but no longer than 3 days. Everyone has been at work every single day to make sure these numbers are out and that the dashboard is updated. And if you see this in regards to the pandemic, the first response was on March 17, 2020. And it's approaching that annual 1-year mark of responding to the pandemic. And at one point in May, we did surpass, I would say, New York, the epicenter at that time. And we thought that first wave was enough and thinking that nothing could surpass that. But our recent second wave, while the United States is on the third wave, we are challenged with these and experience a high number of cases for a long duration of time that began before Thanksgiving. And so, as you can see, there was a really slow downward trajectory that we were still encountering, mainly a lot during December, all the way to after New Year's. We were dealing with numerous holidays and whatnot that contributed likely to these cases that weren't coming down as quickly as we wanted. And a lot of these efforts included public health emergency orders to help alleviate and try to reduce transmission. But everyone had a role in the Navajo Nation. Doesn't matter where or what type of entity you were with, but everyone had a role, and everyone still remains to have a role in responding to the pandemic because it's not over. Overall, the hospital demographics, a lot of questions always come up saying, were you ready for this? What were some issues around healthcare systems? And these are just some earlier numbers. Of course, things could change throughout the entire pandemic when hospitals were either able to expand beds or rooms or and dealing with staff being sick and whatnot. And with a large population of over 170,000 people, we only have about 259 hospital beds and 26 ICU beds and 58 negative pressure rooms. And of course, the ventilators around 74 at one time. And then nurses around 313 and providers 285. As we were collecting information about staff sickness. So this came from some of the reporting earlier on last year when we were getting information about, well, how much staff are sick? Is that contributing to making sure there's enough staff beds for the hospitals? And a lot of assistance came through the first round with a lot of federal entity, non-federal entities in regards to volunteer of large organizations volunteering. And then the second wave was a lot more difficult because everyone, and not only the Navajo Nation, but the entire United States, each state was dealing with high needs and capacity issues. So it was harder to get a lot of response in order to get staffing here. We can have enough beds, but not enough people to cover and oversee those beds when people are sick. And along the way, we've always improved trying to collect data and information. But as you know, I think all healthcare facilities and public health entities across, not only here in the Navajo Nation, but with states, counties, and elsewhere are dealing with not only staff burnout, but also not enough resources and capacity continue to this. But we all try our best every day to respond to the pandemic as much as we can. But this is what it is. And I think their contribution to a lot of this is just the unmet needs from the federal government to make sure we have the correct hospital infrastructure here on the Navajo Nation, enough hospitals with enough beds. And I think there is always a challenge with staffing, medical staffing. Before the pandemic did were already low, or there wasn't enough in the hospitals to begin with. So these are just really things that we couldn't really manage, or didn't have. We didn't have enough to start out with. So that resulted in just the continuing effect of this, how to respond. And we felt that when one of our areas had really high admissions of individuals and wasn't able to keep enough staffing, while staffing were getting sick earlier, right after March. So that's the response and the lessons learned that we have. But I think as we continue in this pandemic, there is going to be limited resources. And I think that's the challenge we're all going to be dealing with. A lot of things that we work together on is just public health response, incident command structure, and how the Navajo Nation is responding in relation to how facilities and the capacity for us to combat COVID-19. We really have to come together. And we do have our government to government relationships between the federal agencies and the states and the Indian Health Service. And we also have relationships with the counties and other resources across the Navajo Nation. And this is an existing structure where we work with BIA and BIE, and also our partners in health with a tribal health organization and Indian health representative and Navajo Nation. Underneath that, we implement a normal ICS structure. And here we call it the Health Command Operations Center, but we also consider our group a unified coordination group as well. And so this is our current structure. We work with humanitarian, we work with clinical response, and also public health messaging, safety measures across the entire Navajo Nation as well. And then also the human resources of dealing with social services also was also a factor, or the collaboration that we currently work with. And of course, law enforcement for the public health orders that we have and we initiate as well. A large part of the response is also the COVID-19 response, which does include health facilities and also epidemiology and several community mitigation groups. And what we're currently working on is the ability to safely reopen one day around schools and also businesses as well. And we do have a finance section and planning and logistics section, and we have a donation section as well in relation to the response. So this structure has helped us a lot in many ways, and it continues to do that. But we always have improvement recommendations as we collaborate depending on the situation. And I think that in the current status of the emergency responses, that we're still in a pandemic, and how we learn from our lessons to work with health facilities is a lot that we talk about every single day. Okay, can you hear me now?
Yes.
Okay, sorry, I muted there. So what's happening today is we do have a public health approach to this whole emergency response as well. And that includes individuals from the Navajo Department of Health and also individuals in the healthcare facilities. What I always like to describe how our healthcare system is set up to individuals that may not be familiar with the Navajo Nation is that in a traditional state health department environment, they have local health facilities, and in those local health facilities, that's where a lot of the public health infrastructure or professionals stem from. But here on the Navajo Nation, that's still quite mixed. And we have public health that are embedded in these health facilities to do health promotion and also disease prevention. And then the Navajo Nation also assumes some of those responsibilities as well. So it's always nice to see how we can work together in addressing not only the outreach and external environment of the healthcare facilities, but we can always try to make differences within facilities in addressing public health prevention. And as we know, in public health in general, sometimes we understand that public health might not have a lot of attention in regards to funding, but I think this pandemic has identified all those weaknesses that we are working on in regards to public health infrastructure. We do have a clinical side of the response as we have public health professionals that are assisting with making sure they help and address foods for COVID patients, or either doing case management or either contact tracing, and also helping with isolation and quarantine the community. We have the clinical part, as mentioned. We have the treatments that are going on, providing patient care to individuals that test positive, and working on transferring those patients to other facilities if our Navajo Nation health facilities don't have the capacity. And I think that has one difference is that we are limited in specialty services. So we do rely on transfer of services to metro areas or nearby cities when we don't have those specialty services that we often really need. And law enforcement is very important in this structure and in response to how it isn't only up to the facilities in this emergency response, and that includes trying to work on enforcement of public health orders and also working on that with the weekend lockdowns or shelters in place or daily curfews that we have, encouraging in our Navajo citizens to follow specific orders so they can contribute to reducing transmission. Of course, the communities, our members are all involved, and we're thankful for a lot of their efforts in adopting the mask mandates or other areas that we have. But we do also know that we still have ongoing challenges with gatherings and whatnot that the nation in the entirety of in the United States deal with. But there is certainly a move towards continuing to reinforce public health messaging around gathering. And of course, tribal leadership does play a large role in this. Our office of the president and vice president have really supported this response in numerous ways. We have town hall meetings every single week addressing the updates for COVID-19, and then also radio forums that we're doing. And then also just encouragement from local tribal leaders to support legislation around how to increase or support funding for the response here in the Navajo Nation. And also volunteers, we can't do this alone. There are individuals that come onto the Navajo Nation, given that they comply with all orders, have supported the local chapters with food or PPEs or other resources. And those are all the appreciation that we have for individuals coming on, because we are a very large land base. So it's not just up to the facilities, but it is a whole effort in the entire community. And in order to bend the curve every single day and move towards hopefully one of these days eliminating COVID-19. And as I mentioned earlier, the collaboration that we do at the Health Command Operations Center every single day is ensuring that individuals are well informed of the public health orders and around curbside dining only or drive-through or either certain businesses open. We have adopted gating criteria that health professionals and safety individuals have vetted in order to respond to the pandemic. Vaccines are very important. We have vaccinated over 104,000 of individuals here on the Navajo Nation, and testing and contact tracing, isolation or quarantine are all mitigation efforts that does include all the facilities and also the Navajo Nation responsibilities in order to respond to the pandemic. So I just wanted to share these comments with you in response to the pandemic. And I have, this was an earlier slide that we did have in the first wave that does show some of this public health orders and the downward trajectory and executive orders at one point as well. So that was good to show and demonstrate. We haven't done this for the last wave that we had, but these are just some images that we encourage everyone to safely stay at home, and then translating some of the CDC messaging. I know someone had commented around the CDC messaging, if those are translated in Navajo. And we also understand that not everyone reads Navajo, even though we speak Navajo. So we try to message some simple messages, but this is one that are posted in businesses and around the Navajo Nation. So just want to thank you for listening today, and I'll end my presentation here. Thank you very much.
Thank you so much, Dr. Jim, for sharing all of that information. It's certainly been an incredible effort during these very stressful times, and your steady leadership has been much appreciated. Would you mind taking a couple of questions now, or would you prefer to wait until the question and answer at the end of the morning?
I can do it now.
I saw a couple here. There was one, is the Navajo Nation still conducting COVID-19 testing? If so, how long will testing go on?
Well, thank you for that question. The Navajo Nation Department of Health is doing testing still in the communities across the Navajo Nation that are in chapter houses, mainly focusing on Navajo Nation employees as well, and to the city. I think there was one in Far Shiprock and also here at St. Michael's, and Department of Health, and it'll continue for the end of the month, and we're finding ways to continue that access to testing. But we also are getting ready to try to strategize on providing access to testing not only to schools as well, as we anticipate someday they'll open, but we need to have a really strong testing program that will not take a lot away from our health professionals, about finding a way for schools to be ensured that they can test. So, but health facilities continue to test, and they have access to testing in their ER or emergencies on an ongoing basis. So that's accessible at health facilities. Thank you.
All right, and just one other quick follow-up. Is there a projected date for BIE schools to open, for staff and students to go back?
Well, right now, school staff they're considered essential governmental services. So I hope that teachers are able to access the buildings to conduct their work in order to provide virtual learning, which we're supporting right now. We are still in the red phase of our reopening plan. It means that our cases are still high enough. And so we're not ready to reopen, but given that we are all going on a downward trajectory, we are following the gating criteria. So I would say anticipate some movement in the next couple of weeks, but not today in regarding to reopening schools. Thank you.
All right, maybe just one more I saw that looked, just came in. Does the Department of Health and the IHS and 638 facilities use the Arizona system ASIIS to report vaccinations?
They, the immunization programs, and they all participate in that. Not all, but all the vaccine are likely being all reported to CDC. But each facility will have its different relationship or collaboration, but most should be reporting to the Arizona system. So that I think makes it really complicated because we require so much from our health facilities to report numbers everywhere. And I try my best to not overburden facilities, but we need data sometimes. But at the same time, I always try to think of not overburdening data reporting, but in order to be in compliance, not only with CMS and state reporting, especially in this pandemic, it's definitely a challenge for our healthcare providers and facilities. Thank you.
All right, thank you. There are a few other questions. We'll save those for the question and answer period if you're available at, we project that to be at noon for a little bit. We have our next presenters here, and it gives me great pleasure to introduce our colleagues from up in Canada. We have Dr. Janet Tsaile of the Métis Nation, Director of the Well Living House Action Research Center for Indigenous Infant, Child, and Family Health and Wellbeing. She's Research Chair in Advancing Generative Health Services for Indigenous Populations in Canada. Her research focuses on addressing Indigenous health inequities in partnership with Indigenous communities. She also does some part-time clinical work. We also have, this is a team effort, Steve Teekins, a member of the Nipissing First Nation with a master's degree in public administration, and he directs the NAMI Res Native Men's Residence. I believe that's in Toronto, where he's worked since 2008. And he's very active in the Toronto Indigenous community, also helping at the Aboriginal Legal Services Community Council program. And we have Dr. Nicole Muir, from who she is Métis and Anishinaabe from Saskatchewan and Red River, Manitoba, currently doing a postdoctoral fellowship with Dr. Janet Tsaile at the University of Toronto in public health. Her PhD is in forensic psychology. You can ask her about that later. She's studied trauma and Indigenous youth on probation, and her research interests include historical trauma, youth justice, foster care intervention, and violence risk assessment tools. She's been an addictions counselor and a traditional counselor at the Anishinaabe Health in Toronto. So currently she's working with the Adoja Mina Nesawinong, which is Place of Healthy Breathing, an Indigenous COVID Assessment and Support Center. And she developed and delivered contact tracing training for Indigenous outreach workers. So we're very interested to hear how things go there in your neck of the woods, as we've been hearing about how things have gone on down here. So go ahead, Dr. Tsaile. I see you have your slides up, and you're welcome to proceed.
Yeah, I think actually I'm going to defer to our community partner, Steve Teekins, to get us started, and then I'll jump in. So I think it'll go Steve, myself, and then Nicole. Community first.
All right. Well, lucky me. Bonjour, Jashko Jeji Wan the Bam Anadonane, this Nakazwa Bashishido Dem, the Basing Nadun. So I just said a traditional greeting in Ojibwe. I imagine probably no one understood a word I said, but that's fine. I just said my spirit name, and I'm the Martin clan, and I'm from Nipissing First Nation. So if we can go to the next slide. I have some colorful slides, and thanks to Nicole for preparing this. So in Canada, we use a little bit of different terminology than our friends south of us. So, at NAMI Res Native Men's Residence, we're an Indigenous specific shelter that works with men who experience homelessness that don't have housing, and we're right in sort of the midtown of Toronto. And in Toronto, there's a disproportionate number of Indigenous people that find themselves homeless. So NAMIRES has been working with Indigenous men since 1985 to help them get housed and alleviate their issues around homelessness. So how it relates to Adoje Mino Nesewanong is initially back in March 23rd and 24th, NAMIRES, we experienced at our larger shelter, a 71-bed shelter, an outbreak. We had our first gentleman who was involved with the correctional system and ended up going to one of the local jails where they tested him, and they found out he was positive. Our contacts from Corrections Canada reached out to me and let us know, hey, we have a positive. So right away, we tried to figure out which room in our shelter he was in and who his roommates were. We encouraged the roommates to get tested. One took off. We never saw him again. He took off. The other one, he went and got tested the next day at the hospital. Next day, the hospital called us to say that he had tested positive. So, and he ran away too. But anyways, that's when we realized, oh, we got a problem on our hands. We might have a mild outbreak. So we wasted no time to communicate to staff that we had COVID. And this was early on in the first wave. A lot of people were naturally scared, not sure what to do. So I'm pleased we communicated to everyone that we had COVID. As a result of us communicating to everyone we had COVID, 20% of our staff asked for layoffs. They were scared. We gave them the layoffs, no questions asked. We recognize that some people live in multi-generational homes with grandparents and young children, and no judgment. If you feel you can't work, then we're not going to force you. So unfortunately, we lost all our cooks in that layoff, and so we hired a catering company. Closing was not an option for us. We have an obligation to work with our men that have nowhere to go, and so we continue to do that work. And then we were successful. I started talking to Dr. Janet Tsaile and another doctor, Indigenous doctor, Dr. Shush. And I just want to make sure we're doing all the right things that we needed to do for our residents and staff to keep the place safe. So I would bounce ideas off them every once in a while, and it would validate some of the things we were doing. And even went as far as sending a really nice letter to all of our staff to let them know that, we are doing a good job and we're operating in a safe manner. And then, one of our managers shared, hey, Steve, we have this vacant building right beside us here. Nobody's using it right now. That would be great to operate a COVID testing center out of there. So, I shared that idea with Janet. And from there, that's what sparked this whole journey that we've been on since, October. Actually, I think it was late July we started talking about this. In October, we opened up Adoje Mino Nesewanong. The COVID testing center, it opened up in ceremony. We reached out to our elder, and I asked him what would be an appropriate name to give us for this testing center. So he told me, he did ceremony and thought over it, and he came back with Adoje Mino Nesewanong. And in Ojibwe, what that means is, the place of good breathing or healthy breathing. So that's the name of the testing center that we operate. And, you want to go to the next slide? I know I'm not very slide oriented and talking much. I'm talking over anyway. These are some of the guys we worked with. And so anyways, once we got the center opened, we were very proud that we were offering this vital service to Indigenous people in Toronto, and, helping them to get satisfaction from getting the tests. So it's been partnership all the way with this. And in Canada, we have the saying for COVID that says, we're all in this together. Well, I can say, quite proudly that we've been in this together with our partners in making this testing center work and drawing upon each other's strengths. And, I never, ever imagined that a homeless shelter would be working with a team of medical doctors and people to help operate a COVID testing center, and eventually trying to shift to operate a vaccination clinic. So that's a bit of the background on why we started the clinic in the program. And the next slide, I'll hand over to Janet and go from there. So thank you everyone for having us in today. And I really hope that you are going to maybe pick up some good learnings from us today. And I know earlier on when we were starting this off that we had a lot of good conversations with some really great people from the Navajo Nation to help us get started. So miigwetz for that.
Thank you, Steve, and Tanze, Janet Smiley, Nitin Sine Kassan. My name's Janet Smiley. I'm a Red River Métis. So my Métis and Cree kin ties and land ties are to the prairies. But I have lived in Takaranto for most of my life. My mom was a Métis nurse, one of few Métis nurses of her time, and she moved to Takaranto or Toronto. So that word in Haudenosaunee or Mohawk means a place, a meeting place. And it's actually home to the most First Nations Inuit Métis people in the city of Canada. So we've got about 80,000 people. But I think similar to the US, there's some jurisdictional complexities. Of course, our various governments have restricted definitions of who's Indigenous, and we have a reservation system as well. So federal policy and some provincial territorial policy likes to ignore First Nations, Inuit and Métis people that move to urban and related homelands, as I call them, I guess because we were supposed to assimilate, but we haven't. So we're alive and well in a vibrant community in Toronto, a lot of diversity, and also very strong network of health and social services, as you've seen from Steve. I just wanted to say how humbled and honored I was then to be invited today to share a little bit of our work. It seems like just a small piece of the puzzle, and actually it was important to me as a reciprocity because the contact tracing program that Dr. Muir will talk about shortly drew really heavily on some of the work that had been done in Navajo country. I just wanted to also say what Steve didn't say was, I mean, I think he did all of that just on his own. So this was the first shelter outbreak in Toronto. We have a high population of homeless people, and of course, Indigenous people, as Steve mentioned, are overrepresented in that population. Steve tried to call Toronto Public Health, which is the largest public health agency in the country, for several days and got no response. In fact, when I heard, of course, as we all do, as people serving community, I reached out to Steve, but he'd done everything textbook, like there was nothing I could add. So it just shows how much capacity that we do have in community. And then Steve was also humble because then we had a little community network that started meeting because there was lots of emerging needs in the city. Of course, the first thing was with the shutdown in the first wave. Many of our community members, 90% of our population in the city of Toronto lives below the low income cutoff. So of course there was immediate food security needs, babies that needed supplies. But then there was also health and social service needs. And at every meeting, Steve would show and he said, well, we need a testing clinic. And we'd say, okay. So finally, as I sometimes do, because I'm an academic and a researcher as well as a community member, I listened to Steve. So we put together a proposal. Another thing though is in Canada, of course, health is run by the provinces and territories, but we couldn't find any provincial money because of these jurisdictional issues. So actually we were able and invited to get some federal monies, which actually had to be research, which seems challenging. The other problem is that we're not really counted very well in urban contexts, in particular in Canada. So by my estimates now, I have a couple data sources. We've had between 1,500 and 2,500 cases. And again, maybe that seems kind of mild, but overall, that's a significant number. It may be the most cases that have occurred in any Indigenous community in Canada yet. Yeah, we don't have the same kind of workforce that there is for our First Nations communities on reserve and Inuit in the North. And of course, we're always very clear, it should never be a competition, it should never detract from making sure the important needs of those communities are met. There's outbreaks in those communities, but of course, it doesn't make any sense in terms of traditional Indigenous values where we would share across non-Indigenous jurisdictional boundaries or in outbreak science to ignore vulnerable people living in urban areas because of some outdated policies. So that's kind of where we started. So after hearing from Steve and talking to community, finally the feds invited me to submit a grant. Actually, that was interesting because what happened is the minister mistakenly mentioned my name as the person that would solve all the data problems and that they'd given me money to do that, but I can't solve all the data problems and they hadn't given me any money. So I called my dean and another professor I work with. I said, what should I do? And they said, be very polite and ask them for money. So we put in an ask to develop a comprehensive public health response. So actually that's a lot of this language comes right from like the Partners in Health initiative. And then we were linked into, and Nicole will speak more about it, to the initiatives that were already happening in Navajo country. But basically we wanted to develop a COVID response system. And we wanted to do it by community for community. If you could please show me the next slide, Nicole. So this is very complicated, as many who are listening know. Of course, when we're doing something in First Nations, Inuit, Métis, Indigenous, Native American, health governance and partnerships are an important place to start. That's paying off now that we're actually starting some vaccination. Because if you build on like the existing community strengths, then actually people will come. Steve, people were saying, well, no one's going to come to your clinic. Steve says, if we open, people will come, and people do come. We're busy. We double book our testing rooms. Of course, then we want to build on it. We wanted to make it an Indigenous model. And in a diverse context like Toronto, we somehow figure out how to do that. And then we needed to staff up. So we were able to pull together an amazing team. We pulled on an agency that delivers services more generally for people who are homeless called Inner City Health Associates. So they helped us recruit nurses. It's interesting because, of course, as all of you know, there's 2 criteria to being a good healthcare provider in Indigenous settings. One is to be clinically excellent, but then you actually have to be skilled in terms of engaging in a respectful manner the Indigenous people that are trusting you with their care. So we were actually, there's always a shortage of people that have both those skill sets. We have outreach workers. We needed to get the word out about our clinic. Fastest way to spread a message is by word of mouth, but how do we do that during times of COVID when we don't see each other as much? So social media, websites, phone lines, and then the testing center. So that was part of a larger project, that this integrated public health response, rapid case management, and contact tracing. So that rapid contact tracing is a key. And I just want to say, of course, we're harmonizing with Toronto Public Health. It's the first time that I know in an urban context in Canada where the large public health authority is actually progressively recognizing Indigenous leadership and sovereignty in the area of public health. But the course that Nicole developed with our community partners, drawing on the models that had been developed elsewhere, including in Navajo country, when she showed it to Toronto Public Health, they said it was better than their training. And actually we're the fastest shop in town in terms of being able to get the results and then rapidly identify contacts and get them tested as well. We have smaller volumes. And then, of course, because there's this problem of identifying the cases, and what tends to happen, there was actually, I heard from public health people, actually Indigenous communities not getting hit as hard by COVID. And I'm like, that's not true. We just hide out from Toronto Public Health, because last time they called me, they were, they'd flagged someone in my family in the hospital after birth, and were going to do a home visit because they didn't think they would be a good parent, or they're following up on sexually transmitted infections. So we've learned more or less in cities as we can more or less to hide when we're using health services. And then finally, it's pretty light. It was research money. But yeah, we have a fairly streamlined evaluation that's led by identifying with community what kinds of short, medium, long-term changes they wanted to see because of the program, and then following up periodically to see where we are with those community set objectives. Next slide, please. So that's just a picture of the clinic, which is one part of our 8-pointed star, which will now be a 9-pointed star because we've initiated vaccination. But as you can see, Steve had this amazing facility. It had been previously used by a community Indigenous health service agency but Steve had already fixed it all up for vaccination. So you can see on the left, that's one of our big clinic rooms. And then you can see our entranceway is quite spacious. And like there's that dual entry that's accessible, which also allows us to move people around in a socially distanced way. Next slide, please. So here again, this is our kind of 8-pointed star for the larger kind of integrated public health response with the outreach, contact tracing. There's 3 core partners, Native Men's Residents, and then 7th-generation Midwives Toronto, and then Well Living House is the research unit that Nicole and I work at. For the actual testing clinic too, we brought in a hospital partner. Women's College Hospital there is another Indigenous physician colleague, Dr. Lisa Richardson, who's done a lot of work there. And they really helped us. A big challenge was making sure, of course, that this would be a place where people would get tested for COVID, but not catch COVID. So of course, making sure you have extremely high standards of infection prevention and control was critical. Next slide, please. So I am going to hand it over to Dr. Nicole Muir, who will bring us around the corner here to and speak a bit more in detail about the contact tracing training components.
Which, first of all, I want to thank you for inviting us today. This has been really interesting. When we first started this, one of the things that I was tasked with, and which I really enjoyed, was to develop a contact tracing training. So we were already working with partners in health. So Dr. Sarah Tsaile put us in contact with Navajo Nation, and they were fantastic. So I was invited to attend their contact tracing training. They provided all the materials for us to use. We did have to adapt them because Toronto, we're an urban population. So we also actually got materials. Partners in Health gave us access to materials from Massachusetts as well. So we kind of combined those and then worked with our community partners. So our community partners were Steve from NAMIRES and Sherilee Bourgeois, who's from 7th-generation Midwives of Toronto. So when I developed the contact tracing training, what I wanted to do was to think really holistically. So we actually have data in Toronto. Dr. Smiley and 7th-generation Midwives, about, I don't know, 5 to 8 years ago, they did an Indigenous health survey, which was the community chose the questions, and it was self-identified Indigenous people who did the surveys. So what we actually do have really good data on urban Indigenous people in the city of Toronto. So when I do the training, it's not, I do the training for Indigenous outreach workers, but I also did it for the non-Indigenous staff. So some of the clinical staff is non-Indigenous. So it's really important for me that they have a holistic understanding of what's happening for Indigenous people in the city of Toronto. So we have data from our Health Counts survey about comorbidities for Indigenous people, housing, poverty, so anything that's a risk factor for COVID. Then we did some research and we looked, there was Johns Hopkins and ASTHO had online training for COVID. So we decided to go with ASTHO. It was, I thought, a little bit more user-friendly.
although we encouraged our staff to do both if they wanted. And then a really important part, of course, to make sure that the staff stayed safe was we had IPAC training. So to make sure that they were following all the protocols to keep themselves and the Indigenous community that come in for testing to keep them safe. Because we basically were developing a testing center, a support component for outreach workers and contact tracing, there was a lot of different pathways. So what are the staff roles? How do clinical staff work together with the outreach workers to make sure that the Indigenous community members that come in, to make sure that they're treated very well and get all their needs met. We also, because we were doing a small research component, we, all the staff had to get ethics certificates. And this was for our research ethics board. The contact tracing components and the script, we got support from Navajo Nation and COPE. And COPE is Community Outreach and Patient Empowerment, which is an offshoot of Partners in Health. One thing that we really wanted to focus on and make sure was that the Indigenous community members that came in for testing, whether they had COVID or not, and whether they decided to be in the research component or not, we wanted to make sure they had lots of resource support. So if someone came in for testing, we would hook them up with an outreach worker to make sure that they had, if they had to isolate, whether they could isolate safely at home or if they needed to go into an isolation hotel. And we wanted to make sure that they had enough food for 2-week isolation and that they had enough medication, and also that their mental health and needs were met. So that is something that our outreach workers follow up with everyone who gets tested at a doge. I also, because I come from a psychology background, I wanted to make sure that all the staff were trained in trauma-informed care and motivational interviewing. And I think motivational interviewing works really well because I have done a bit of the contact tracing. And one of the things that I found was when I first would call someone who had a diagnosis of COVID, they were very scared, upset, and often, you know, they didn't maybe want to talk about contact tracing at this point. So motivational interviewing is a really good way to build rapport and also empower our community members. We also had follow-up scripts. So we call individuals who have tested positive with COVID. We call them every day. So we have a follow-up script to make sure that all their needs are being met, and also to make sure to follow their health as well. Another important component that I wanted to include was self-care for staff. This is difficult work. I know at Adoge, they are so busy. The outreach workers are extremely busy running, trying to make sure that everyone is supported. Importantly, we also had to make sure that we are following the Ontario Ministry of Health COVID guidelines. So, because if we're not, then we're not ensuring, you know, the best care for our clients. So that's another component that the staff is trained on. And we also make sure that they keep up because the Ministry of Health releases new guidelines periodically. And the other component is continued training. So we make sure that recently I gave a training on motivational interviewing for the staff. So whenever, if they have ideas where they want extra training or support, then I can develop that training for them. So one of the things that I wanted to just show you is one of the things I think that makes this training really good is I worked with some of the outreach workers. One in particular has a lot of experience working in the community. And so together we developed scenarios. So this is an example of a scenario. So Bobby is a 75-year-old grandmother who identifies as female. She lives in an apartment complex in Toronto. Her symptoms started on March 29th. She was tested the same day at a doge. She had dinner with 4 friends. On March 28th, she went to Native Canadian Center. Near the end of your call, when you're assessing which resources Bobby might need, she starts to have a difficult time breathing and seems confused. What should you do? So that's just an example of how we wanted to make sure that our outreach workers when they're doing the contact tracing calls, that they're really prepared for any situation that comes up. So I'm actually just going to leave it at that. Janet, do you have any other comments or that you want to talk about?
I guess the other piece just that's contextual is one cannot understate how difficult like externally imposed jurisdictional challenges have made things for us, even just to set up like the testing site and now just with vaccinations. So Toronto is the biggest hotspot in Canada, probably along with Montreal. We know in our community, we have the UK variant, but yeah, the vaccine is flowing very slowly. So we've had 2 vaccine clinics so far. Vaccines flowing slowly for us anyways. But yeah, it's just politics that make things very difficult for First Nations, Inuit, and Métis in urban areas. But one should also not underestimate then existing capacities within all First Nations, Inuit, and Métis, and Indigenous communities. In my mind, that's a common error that happens by outsiders and also sometimes within our communities. And then just the power of like working across jurisdictions and boundaries. And of course, this whole collaboration where we reached out to the Navajo Nation and now we're back sharing a little bit is a good example, as also what we've been able to do locally during COVID. So yeah, thanks very much. And yeah, we're happy to take some questions. And I hope this was useful.
Yes, thank you very much. I really enjoyed hearing about that, how you work with others down here to get help and assistance, and how you listen to community and work, directly towards meeting those needs, very bottom up. So thank you for that. There were some, let's see, do any of the panelists have questions for these presenters? I think there were a couple of questions, and Steve Teakins managed to answer them in the question and answer by just typing in some answers to people. So I think all the attendees see the answers. I'm assuming.
The question I answered was, what kind of swabs do we use? And now keep in mind, I'm not a medical doctor, okay? I just did nasal swabs and saliva tests. So I don't know if there's a proper medical term for those, but that's the kind of testing we're using currently.
Yeah, so we're using, so actually people have a choice, and we were able, one other interesting thing again, because yes, sometimes hospitals, we have a large concentration of academic teaching hospitals and they tend to compete. But luckily, different people in our network had affiliations with the different hospitals. So we spoke about how Women's College Hospital had reached out and supported our IPAC training, and we did an IPAC audit. We were able to access testing through my home institution, St. Michael's Hospital, Unity Health Toronto. We had talked about getting rapid testing, but we actually get our test results back within 12 to 24 hours from Unity Health Toronto. And because the nasopharyngeal swab they do there is better with respect to sensitivity or specificity than the rapid testing we could get our hands on. And it was pretty critical because some of the things, in addition to diagnosing COVID, we were supporting people to be able to access their kids or treatment programs. So people were heading in to congregate settings. So we wanted to make sure we had high sensitivity and specificity. But we were also able to access saliva testing from another one of our big academic hospitals through another one of our physician colleagues that had an affiliation there at Mount Sinai Hospital. So that was quite good because it just was empowering to community members. As you know, because we have high rates of complex trauma and violence, anything that approaches the face could be quite threatening, and it's scary for kids. So we could offer them the saliva testing as well. And if somebody wants to know the specifics of the swabs, we just went with the nasopharyngeal swabs that were being used at the institutions where we're at. With respect to the vaccination now, and again, you're way ahead of us. I think I heard that there was over 100,000 vaccinations given. So yeah, congratulations. We'll just follow humbly in your trailblazing efforts. But yeah, we're able to use the Pfizer vaccine in partnership then with my home institution, which is kind of nice because I don't know how much people pay attention to what's going on here in Canada, but we're kind of a modest country. So we've yeah, had some huge vaccine supply chain issues over the last month, which is probably the worst possible timing. But yeah, there's a bit more Pfizer coming in. So that we were able to figure out a way to get the vials over to our center and then prepare the vaccine on site. So thanks so much for the question. I also put up, in case anyone's interested in that, our health counts method, which again would be more relevant for Native American populations living in urban areas, because of course our First Nations communities and on-reserve tribes, at least in Canada, they have a very good knowledge of their own membership, more or less. But in the cities, it's hard to find Indigenous people. So we've been using respondent-driven sampling. So happy to chat if people are interested in that as well.
And have you seen some of the questions here in the question and answer? I think principally from Diana Yellow, who's one of our public health alumni here, wondering about how the issue of race impacts your ability to provide these services, I think, and be able to finance them.
Yeah, so unfortunately, as I'm sure many on the call can relate to, anti-Indigenous racism is alive and well. I mean, Toronto is a diverse city, but still, even across some racialized groups that are non-Indigenous, we see anti-Indigenous racism. So there's a lot of biases, and healthcare providers who are not aware of these biases then are discriminatory or have differential decision making and do not adhere to clinical practice guidelines. So that's where it is so important in the urban context then too. And again, it's so different, right? Many people have survived for many generations then by being very picky about in what context they announce and celebrate their First Nations, Inuit, or Métis identity. And you can even those who may be visibly recognizable as not white, because we have a diverse population that's racialized, they may be feeling less vulnerable if they pass as another racialized group. So for example, I can get misracialized as white, but also as from Greek or some other part of the world where people have an olive skin tone. And yeah, even as a very privileged physician and academic, I still sometimes think twice about self-identifying. And we say here in Canada, unfortunately, in cities like Toronto, it's actually the exception is when one of our community or family members goes through the healthcare system, particularly hospitals and emergency rooms, and they don't experience discrimination. So that's why we're really advocating to draw on this amazing strength. So we have 20 plus Indigenous specific health and social services in a city like Toronto, where Indigenous people have been coming since the 1940s and 50s. You know, and there's always, you read about the first in the 50s that would open their house to all community members that would come in. So that's expanded. So that's the huge advantage of building on that network with the vaccine efforts. So we're, I think, slowly getting that message through to the policymakers who also, because we're setting up like a big amusement park, our city hall for vaccination. But again, yeah, how could it be culturally safe for people to identify? I think my battery might be going in my headset, so maybe I'll defer to some of my other team members to answer questions or comments.
So yeah, Dr. Yellow, I guess for terms of getting funding for our center, it's been a challenge at times, but I'm pretty quick at finding funding. I don't know, I wouldn't say I'm good at it, but I've been really good at it for this project. So, you know, funding hasn't been jumping at us, but we've been able to find enough funding to function. And I saw another question asking if the medical staff, if they're volunteers. No, we've used that funding to pay for their services, and to make sure that that is there for them. So so we have nurses on staff. We have a nurse practitioner. We have a couple MDs as well that are working at our clinic. So they perform a lot of the functions that we need to keep it running.
All right, thank you.
I see a question as well about titer testing. So yeah, we haven't, like, seroprevalence is tricky, partly because it involves drawing blood, and we're already in a group of people who feel like they've been researched to death. And then of course the serology science has been evolving rapidly. So we did have a big national initiative that started during first wave for us here, which ended in the summer for most parts of the country, the first wave. But then we got hit by the second wave. So we've been all hands in deck, just testing, trying to get rapid contact tracing in place, and then get the vaccine implementation up and running. So there is some serology, but yeah, I was on a national committee looking at it, and some of our research leaders, Dr. Jeff Redding, Dr. Carrie Barassa, some of you might know, were trying to lead that, but it was really complex to implement that. And part of it is just the hesitancy already in our communities around research. And then to actually do a blood draw would be very tricky in a very quick manner, because of course, as many of you can relate to, many of our values would be around that being kind of a sacred material. And of course, with the blood draws for serology, people were interested in genetics as well. So it was complicated. As far as I know, I haven't seen any published like serology in Canada. I think we may be included in some other serology studies.
There was a question here about whether the pandemic has bettered the relationship between public health services and tribal nations.
I would say, from my experience, when I meet with them, I always remind them that they never answered my calls, that they were never there, that, when we needed them, where were they, right? So I'm one of those guys that just says it how it is, and I try to do it nicely. So, I have to give them a break sometimes. I know with our local public health units across the province of Ontario, when we got our new conservative government here, one of the first things they did was cut all the public health units across the province. So imagine when you have big cuts like that in units like that, the best and brightest often leave. And, so I know they were understaffed to begin with, and probably weren't in the best position to respond to this pandemic. So, I say that somewhat lightly, but has it improved? I think they want to improve the relationship. I think they, maybe are a little more collegial now when they work with us. Perhaps maybe Nicole or Janet might have a different response than mine, but I think they seem to want to work in collaboration with us now.
Yeah, I think there's been room to grow. I think it's really powerful, like Steve's story and how public health didn't meet the call. We see it like we're lucky because we've had the opportunity to develop our own contact tracing. So we hear from other service providers, because of course there's other agencies that are doing testing, notably the Anishinaabe Health Toronto, but they are using Toronto Public Health. So then they'll call us and they'll say, oh, we were surprised it took a week for Toronto Public Health to get back. But of course, I also have been talking to infectious disease colleagues. So, I mean, it was taking 2 weeks, like at the beginning of the pandemic, right? So I think that one thing there's a bit of a milestone. So we're having some discussions because public health does have some data about Indigenous identity. They are asking about it. I think it's probably like a huge undercount. But some of the community agencies, NAMI-RES and SDMT, are talking to Toronto Public Health about developing a partnership with Well Living House so that Indigenous people can be involved in data that is about them. And then of course, yeah, we've been working hard on harmonizing this pathway. So, you know, moving from Indigenous data sovereignty, moving it into the area of public health, because of course, like you all probably, we're subject to like provincial and municipal laws. So actually we're starting to create some wiggle room and get them to actually see our capacity. Of course, and we have, and then like anything else, it's important to have the good relationships, and there's certain individuals that have really helped us, but then there's other individuals like we had to deal with somebody from Toronto Public Health, like just putting down our contact tracing program, saying it wasn't real public health. But of course we took that back to them and complained, and now we have special people that hear about our cases and like are oriented and actually know and recognize the value of what we're doing. So it's always that juggle game. You gotta try to do things even a little bit better than mainstream, to show that you're capable and push back, but with civility. So yeah, I think we're combining some of those aspects and find your people in the system, the allies that will really hold up your work and support their colleagues in doing that as well. I don't know, Nicole, did you want to add anything? Because you had some interface with them around the contact tracing training.
The only thing I want to mention is there are, again, Janet said, some really, really kind allies at Toronto Public Health. But one of the things I noticed was when I was explaining how a dojo was going to work and the staff we had, and that we had, you know, 2 Indigenous physicians, and we have an Indigenous nurse now, they were surprised that we were so competent. And that, you know, that really spoke to me. And I mean, that's a bias, and they weren't even aware. And the person who said it was very kind and was just saying, wow, like, and I'm like, we know how to take care of our community members. We know how to take care of ourselves. We've been doing it for thousands of years in North America. So that was one thing that really stood out for me. But I think some of them are really coming around, and it's good. We're at least at the table now. So I will leave it at that. Miguel.
I don't know how we're doing for time, but I see a couple of accumulated questions. I figured I had to open the question panel. I'm still getting my Zoom training, but did you want me to try to run through a couple of those, Mark, or do we need to move on?
I was kind of curious if you could quickly answer that one from our Navajo PhD colleague, Dr. Jenny Jo, and wondering, you know, how is it for those living on the reserves? Is it different there?
Yeah, so thank you. Always honored to have a question from Dr. Jenny Jo, one of my heroes. So it is different. The response is different, and it varies across the country again, because First Nations, well, health is a provincial territorial jurisdiction. So yeah, as we worry here in the city of Toronto, there are outbreaks happening in First Nations communities, but overall, because of the way health is set up, there's been more time and more directed towards responses for First Nations on reserve, which is good. It's still an under response. And again, I always try to frame my comments to make sure it's not ever mean like I'm undermining like the need to have needs-based and equitable responses for my First Nations relatives who are on reserve and for Inuit in the Northern Territories. Right now, I would say that the large majority of vaccine in Ontario has gone to First Nations on reserve. Quite rightly, some of the fly-in communities were recognized as at risk of higher consequences if there was an outbreak, because community members are living in appalling housing conditions that are overcrowded and also would have trouble getting out if they got very sick because they're far away from health services. The hard part is right here in the city of Toronto, where we have more doctors and more hospitals clustered in like a very small area than anywhere probably in the country. Yeah, again, there's barriers. So our health status outcomes don't improve. And when we look at the health, our health counts data, because it's very expensive rent in Toronto, the housing is different, but it's overcrowded, multi-generational, and people are homeless. So they're different contexts. but they both have extreme challenges. So I would say that the jurisdictional barriers and the history of ignoring First Nations, Inuit, and Métis in cities is negatively impacting like the kind of response that we need to see in the urban centers, which are the epicenters. And of course, our tricky relative, COVID, doesn't care about the Indian Act or on or off reserve or city or rural or remote. And in fact, our strength, like in our kinship ties, like people are traveling back and forth. So we see a repeated pattern on First Nations, on reserve communities in the Northern Inuit communities, where outsiders, but also community members are bringing the germ in, right? And it's very hard. Our First Nations leaders were very proactive during the first wave and the second wave in terms of closing borders, but it's very hard to say, you know, no to your uncle that's been struggling in the city, you can't come in, right? Or your niece who's coming home. So that's where we say, and then of course, or your relative who's been incarcerated. So what I think the big problem is that there's these colonized silos that have been more or less internalized. So things, if again, yeah, I would say that, yeah, the fact that we've had less than 200 people vaccinated in the city of Toronto, which is the hottest spot in Canada right now. And yet, like thousands and thousands of vaccines going into First Nations communities on reserve. So that's good, but thousands of vaccines going everywhere across Canada. So yes, there's 70,000 people at risk in the city of Toronto that are Indigenous with a concentration of intersectional risk factors. So 200 vaccines is not enough. The resources that have been shared to address like the acute and worsening food insecurity and housing instability are not enough. And of course, as I imagine many of you would agree with, like it's got to be by the people for the people. So we still have to, we do have this conservative government, but we have to continually say, just let us do it for ourselves. We'll tell you what we need help with. And the problems that you're talking about will go away. Like how many times did I hear, well, how are we going to know who's First Nations, Inuit, and Métis in the city? And it's like, yeah, ask the 20 Indigenous health and social service agencies that have been serving the community for the last 70 years, up to 70 years, and we'll tell you how to do it.
Thank you.
So definitely racism in terms of the vaccine access then. And then to get people back and get the second dose, that's where we'll use our social networks, right? So there will be challenges, but that's where this strength of relationship and pre-existing relationship will help us. And we're actually, there is another, the Anishinaabe Health Group is looking at vaccination, and hopefully we'll be able to actually have a couple of sites so that we can cross over. Someone misses their second dose appointment at one site, we know the other site's having a clinic the next day or the day after. And so I've been speaking with Dr. Lisa Richardson, who's the technical advisor there. And if we can, we'll try to build that kind of cross collaboration and cross referral that will help. And then we're also looking at optimizing mobile vaccination and outreach. Steve, or did you want to add anything there?
I just know in some of the First Nations communities, you know, on every other weekend, I go back to my girlfriend's community to visit her family and help her ill father and you know, get groceries and that stuff. Their approach has been they've closed their territorial borders to outsiders. And I found that in Ontario, at least, and I think in other parts of Canada, a number of First Nations have closed their territorial borders while others have not. So it's been a mixed bag of approaches across Canada in terms of our First Nations communities. I know in my First Nation, they never close their borders, but we have 5 different communities all stretched along the highway. So I think it's kind of hard when you got a major highway cutting right through the middle of your territory. So yeah, I don't think there is one uniform approach that our First Nations across Canada have used. It's been a mixed bag of approaches that works well for whatever the local communities feel is right for them.
Okay, yeah, we don't have very much time left, and I see that Dr. Leandris has joined us from CDC. I remember there had been a question earlier about, when you had a slide up about people getting vaccinated and percents by race. And she was wondering if the lack of vaccinations among some of those groups are more the fear of vaccination among those groups, or whether it's more of availability or access to vaccine.
So I would say it's a combination of both. There's a huge amount of distrust that remains in communities, and also availability. There's a lot of press and push coming from local leaders, of communities of color, really asking why there isn't more vaccine available in those communities. And so, again, it's an area that we, certainly from where we sit at CDC, are continuing to also, be part of those discussions to improve access and accessibility as well.
All right. And there were a few questions for Dr. Spector. I didn't know if he was answering any of those himself in the chats, as some others have done.
I did answer a couple.
Okay, yeah, there's a question about whether the virus could be transmitted back to an animal from a human, since they come from sometimes the other direction and then mutate into another form.
So viruses have a great tendency to be species specific, and so they don't easily cross from one species to another. However, we know from this example that they certainly can do that, but you're not usually going to see them going back and forth and mutating from human to animal, back to human, back to animal. So that's unlikely. We have a name for animal viruses that get to humans. We refer to those as zoonoses. And those are not uncommon, but they don't happen easily. So I don't think we're going to see a ping pong effect with the coronavirus and have it coming back as a changed virus because it went through animals.
Okay. Yes, the questions vary from things on the social end of the continuum all the way to the deep into the virus structure itself. Are there any questions that the panelists have of any of our speakers this morning? Okay, I see Dr. Hakim is putting up our list of, yes, question and answer. We did see another question here from an attendee from a public health approach. How are racial disparities a conflict with COVID-19? That could be a question to anyone, I think. Possibly to Dr. Leandris.
I'm sorry, taking me a long time to come off of mute. So I guess I'm trying to understand racial disparities, a conflict with COVID-19. I'm not exactly sure how to interpret the question, but as I said earlier, COVID-19 has really exacerbated long-standing, certainly racial and ethnic health disparities. And I think it's exposed racial inequities and those social inequities that come along with that have also been exposed in a big way. So I'm not sure about the conflict, but I can say that COVID-19 has really shown a bright light for people who have said they didn't see these disparities and inequities before, it's impossible not to see them today.
Yes.
I'd like to add on to that. When we think of healthcare disparities, we're always talking about access and those type of issues. But a more fundamental issue has to do with the clinical trials. And often when we have clinical trials, we just see a Caucasian population. And we assume that the results of those clinical trials are generalizable. And that's not necessarily the case. We saw that with anthracyclines in cancer, where they do find if you're Caucasian, give it to an African American, you're going to induce heart failure. And then we saw on the other hand with, say, cases of lung cancer, where epidural growth factor inhibitors were not used because for 10, 15 years, because there was no results among the Caucasian population. But now we use them because they work fairly well with the Asian population. And we can say the same thing with some of the vaccines. We cannot assume that a one size fits all. We cannot assume that different ethnic groups are going to respond the same. We saw the same thing with the HPV vaccine. Had devastating effects among Hispanic populations. And so what's important as we go forward with vaccine development is to be inclusive, to make sure there's enough African Americans, make sure there's enough Hispanics, make sure there's in order for those clinical trials to be valid for all of us.
Yes, very valid point. Okay.
Dr. Bauer, could I share one thing? One of the questions that was asked, and I needed to check in with my colleagues, was about do we get data from IHS and 638? And so what I found out, the message I have is that we receive vaccination data from IHS tribal and urban Indian clinics through data submitted by IHS for those sites receiving supply from IHS, and that's a separate federal allocation, and also immunization information systems where the state supplies vaccine to the IHS tribal and urban Indian clinics. And so, so the answer is yes, we do get vaccination data from IHS, and it would be included in the data that I shared. And then in terms of 638, they said the term 638 contract, or more formally a self-determination contract, are shorthand for the Indian Self-Determination Education Assistance Act of 1975. Sure, I don't need to tell you all that, but it has, and what he said is, I'm not sure how it applies here in terms of the data piece. So I just wanted to share that. And as I get more specific information about these questions and the data sources, I will certainly share them with Dr. Hakeem. So I regret that I have to leave, but it has been, I have learned so much for the parts of the conference I've been able to participate in. And I wish all of you well, and please continue to take care of yourselves and continue to advocate on behalf of your community. Thank you very much.
All right, thank you. And I think we are officially out of time now. And so this will conclude the morning session. So we can have a little bit of time to walk around and look outdoors and grab something to eat or drink, and be back here at 1.
Thank you very much, Dr. Mark. see you all back at 1 o'clock, and Dr. Scott Bender will be taking over then. Thank you very much.
All right.
Thank you, Dr. Mark, for all the help. Thank you.
Great big thanks to all of
Thank
our.
you, Dr. Janet Ismaili, Dr. Nicole, and Mr. Steve. So we will be very happy if you will be joining us after the session also. But like we know that you all are very busy and doing a lot of other stuff. So thank you very much for accepting our request to be part of this conference. We share a lot and we learn a lot from this, and hopefully we will be able to use all this knowledge for some of our future work. Thank you very much. Thank you very much.
Okay, see you after lunch.
Mm-hmm. Dr. Ian, if you are here.
Yes, hello.
Yeah, yes. So if you want to check, you can check if you want to see your screen sharing.
Absolutely. I'll check that really quick. Could you please end the current screen share?
Yep. It looks good.
Good, thank you.
Mm-hmm.
Shalia, just so you know, the Facebook Live went off again, so we'll need to get that restarted before the next session.
Okay. Thank you very much for letting me know.
Test 1 2. Test 1 2. 3 and 4 2. Oh, maybe 5.
Hello there, it's Mary Jane speaking. How are you?
Very good.
Yeah,
Welcome.
that's good. Okay.
How nice and warm is it up there in your Great White North today?
Yes, it is. I don't even know what it is, but it's been minus 40, 30 and 40 all this week, this past week.
We had a tropical heat wave. We finally hit 10 degrees.
Oh, did you?
Last night, yes.
Yeah.
And you can start.
Okay.
Mm-hmm. Over to you, sir.
All righty. Welcome, everybody. Welcome back to the afternoon session. I hope you've had a good time. We have some grand guests from north of the border as well as some folks from here on Navajo that have really made a difference. And we have some guest speakers that also will be speaking about how this COVID virus acts, operates, and otherwise is a nasty little critter. Real quickly, my name is Dr. Scott Bender. I am a professor here at Diné College in Tsaile, Arizona. I joined faculty a couple years ago. I practiced and actually was one of the tribal veterinarians for the Navajo Nation for well over 20 years and specialized actually in the area of foreign animal diseases. So this COVID coronavirus is no stranger to the things that we prepare for. And in fact, Real quickly, one of the things that has been kind of lacking is the voice of veterinarians in this particular outbreak. We have been dealing with outbreaks for years, and the Navajo Nation should be given actually kudos, because in 2003, we in 2006, the Navajo Nation actually enacted the first tribal foreign animal disease response plan, so we could deal with outbreaks like coronavirus that affect our livestock and our livelihood. So, and the one thing before we get started, please do not vaccinate yourself with the bovine coronavirus. Yes, it is a beta corona like COVID, but it does not cross protect. Please, please, please do not use Ivermectin. That's a cow dewormer. And then just to kind of bring it into perspective, this is not the first disease to cross from animals into humans. And in fact, our measles, which is still with us today, most likely arose when we started living with cattle. It probably started as the disease rinderpest and then jumped species. Now, enough of that. Please, I would like to introduce the Honorable and Senator and Dr. Mary Jane McCollum. She is a Cree woman from the Barren Lands First Nation in Broquette, Manitoba. Her husband Ron Phillips is a professor at Nipissing University, and her two daughters, Courtney and Keely Phillips, are both lawyers, one working in Saskatchewan and the other in British Columbia. In 2006, Mary Jane reunited with her son Jonathan, whom she gave up for adoption in 1975. She started her career in the dental field as a dental assistant in 1973. Mary Jane then received her dental nursing diploma in 1977, dental therapy diploma in 1979, and her dental degree from the University of Manitoba Facility of Dentistry in 1990. Mary Jane spent most of her past 45 years providing dental service and treatment for First Nations in Manitoba as a dental nurse, dental therapist, and then dentist. From 1996 to 2000, she worked as the regional dental officer for the province of Manitoba. In 2000, she worked as an assistant professor in the Faculty of Dentistry at the University of Manitoba. Yet her passion has always remained working with Indigenous people in the community-based settings. Mary Jane went to Guy Hill Residential School in Manitoba in the 1957 to 1968. Mary Jane continues to present to school children, university students, academics, and communities about residential schools. She believes that Canada must never forget the genocide of the original First Peoples, and that a lateral and vertical violence against Indigenous people still exists today as a result of sustained governmental policies. On December 2nd, 2007, Mary Jane was appointed to the Senate of Canada as a representative of the province of Manitoba. She assumed this mantle with reconciliation top of mind, recognizing its importance for Canada if we are to be recognized as human rights leader. I would like to turn it over to her and her opening prayer.
Thank you very much. And you can hear me?
Sound great.
Okay. Okay, I wanted to start with a prayer just to acknowledge that the Creator is with us. And when we offer our prayer, He comes down to join us and be part of this conversation that we're having. Kitsimanitu kinanas kumitten anots. Kitomi wanskayan. Kitom tawa patamanaski. Igosti it niwak. Kinanas kumitten idomistay median. Questigas kitayan tamam tunidi taman. Tawapian. Tantutaman. Tayamian. Iguasti tayamiayan. Questigas kidi taman. Igoskitayan. Questa pachitayan chichia igostin skata. Kinanas kumitten. Thank you, Creator. for the privilege of waking another day, for giving me breath once again, and for letting me see the earth, our mother, and for connecting me with the people that are here with me today. Thank you for all that you have given me, for the ability to do critical thinking, for the ability to see, to hear, to speak, and to pray. Thank you for giving me the ability to be able to use my hands and my legs without any issue. I thank you very much. Okay. Okay, so I'm going to switch gears here. I'm not going into as much into science. I wanted to go into more into Indigenous knowledge, and there will be some stats in here, but it's a combination of prayer, of situating ourselves as Indigenous peoples in the context of COVID and the multiple traumas we go under, and as taking our rightful place. The COVID-19 pandemic is not only about the existence of a virus, it is much more about why this virus has succeeded in wreaking havoc despite all the scientific knowledge and research and all the Western knowledge and experience that has been collected from past pandemics. It is imperative to examine why, despite this knowledge, COVID-19 hit hard for all Canadians, especially the elderly in care homes, but harder still for First Nations living on and off reserve, especially in northern Saskatchewan and Manitoba. First Nations were an afterthought for many. Despite the lack of data, the lack of coordination between federal and provincial governments with resources, the lack of timely aid, First Nations have persevered. It's important to document the truth behind the facade that we are treated equally, but not to waste too much energy on it. As stated in the Being Called to Witness, quote, to be able to research, record, and retell truths about unsustainable fallacies is to realize the internal hope of survival that the Indigenous peoples continue to hold across Turtle Island. Aboriginal peoples are determined to not disappear under the weight of the cultural, political, social, and spiritual devastation of colonial inertia, by Sefi D. and et al. 2000. Indigenous scholars are tasked to address this crisis of knowledge by retelling the tragic consequences of the past 7 generations in a voice that resonates with resilience and pride. That's on page 122. Before I go any further, I want to share an experience I had in December 2019 when I went to British Columbia, Canada, to attend an Indigenous gender-based analysis conference. It's called Being Called to Witness, which is a Coast Salish and Interior Salish peoples of Canada tradition, dating long before contact with European cultures. The role of a witness is to record the message of the event in their hearts and souls and minds, and afterwards remember and validate the special occasion by carrying and sharing it with friends, neighbors, and community members. That's Indigenous Self-Discovery, Being Called to Witness by Stephen Kopke. I was asked to bear witness at the end of the 3-day conference, and it has always stuck with me and James Campbell, the Director of Parliamentary Affairs I have had the privilege to work with since I became a senator in December 2017. He's with us today watching live and has worked on Parliament Hill for over 10 years. What I'm bearing witness to today is how the strength of a people, individual and collective, who have retained Indigenous knowledge tempered with natural laws, social capital, in Cree we say witi twin, it means working together, strength, isogatsuyan, it's being strong, resilience, resistance, blood memory, which includes land-based education, including the spirituality, ethics, accountability, and holistic thinking that is demonstrated in our languages, has the ability to withstand the ravages of COVID-19. I've had to learn to situate myself continuously, especially when I'm in Senate. So this is what I think when I'm going to speak or there's contentious issues on the floor. As Indigenous peoples of Canada and the United States, we continue to learn a lot about the impact history has had on ourselves, our communities, and our countries. We continue to learn a lot about ourselves as business owners, caregivers, change agents, and about our relationship with the state governments, whether they be federal, provincial, or territorial. We continue to learn about the power imbalances that exist, about our historic and ongoing struggle against land dispossession, allowing resource extractive industries power over our lands and people. We continue to learn about human rights violation in our homelands, identity, genocide, geographic, environmental, and political racism, economic development, Indian governance system and Indigenous legal traditions, racisms in institutions, domestic terrorism against Indigenous peoples, food and water insecurity. We also continue to learn about intergenerational trauma, spiritual trauma, over-incarceration of First Nations, violence against women, with the missing and murdered women, child kidnapping through residential school, child apprehension, and the 60 Scoop, interjurisdictional wrangling between province or state and federal governments, constitutional challenges, multiple chronic condition, increasingly complex medical histories, living in states of different emergencies, whether it's water or fire, resulting in community evacuation. And as you all know, the list goes on. We are in fact not only facing COVID-19 pandemic, but multiple pandemics, some that have lasted for centuries, slow, continuous, and insidious, but cumulative, complex, and multi-layered. Martha Cabrera from Nicaragua describes it best when she refers to her society as multiply wounded, multiply traumatized, and multiply grieving after experiencing several decades of conflict. And that's from the Little Book of Trauma Healing by Carolyn Yoder on page 12. In Canada, addressing the problems highlighted by the COVID-19 virus will always remain inadequate if done in a siloed manner, biologically and scientifically, and without the intersectionality of the social and political determinants stated above, and without First Nations meaningful contribution. So we must ask, what was the landscape that welcomed this virus with open arms, allowing it to wreak havoc the way that it has? Canada had 10 years to prepare since the 2009 H1N1 pandemic. In the submissions I made, I have submitted reports from Senate, including the COVID interim study that they did. So you'll see that they did a study on H1N1, and the report made recommendations to the Public Health Agency of Canada, Health Canada, Public Safety, and the 3 recommendations for First Nations Métis on Inuit on addressing social determinants of health, data gathering, and the responsibilities of the federal government for the on-reserve population were not considered. So the question I asked to the government was, why would the pandemic situation change with COVID-19 if the landscape was left the same as it did during H1N1 in 2009 for First Nations both on and off reserve? Manitoba, the region I represent in Senate, has 63 First Nations, including 6 of the 20 largest bands in Canada. 12 of these are not accessible by road, and they rely on air transportation. The winter road opens next week to bring in the gas, to bring in groceries, and it will likely last 3 to 4 weeks, and then it has to close again. In my home reserve, Brochet, the gas was sold out in Northern Store in January, but fortunately the band had gas reserves. The men need the gas to go hunting for caribou, sometimes 8 hours away by Skidoo. They also need to get firewood in the event that the hydro plant ceases to work. Internet is not available to all and is very unreliable. There was no data available during 2009's H1N1 pandemic in Manitoba, but limited data did become available after the fact. I worked in the nursing stations through the H1N1 pandemic. And while I was on one of the reserves, they were medevacing out a patient, and I went to the nurse and I asked her if they were swabbing the patients to confirm for confirmation of H1N1. She told me that the nurses were forbidden from swabbing patients by the head office in Winnipeg, which is the capital city of Manitoba. So there will never be true data collected. Not only do questions linger about the accuracy of any data collected, there continues to be mixed messaging and incomplete, if any, concrete data given as it pertains to the Indigenous population as well as other minority groups. This is evidenced by the fact that the province of Manitoba announced yesterday that they are not prepared to share any of its COVID-19 demographic data concerning racialized groups. This is despite the fact that the provincial government has been collecting race-based pandemic data and asking people about their ethnicity since May the 1st, 2020, but has continually refused to release this data. Despite this lack of specific and crucial race-based data from the province, just this morning, the Canadian government released their most recent COVID-19 modeling forecast. This forecast shows that more transmissible variants could drive the resurgence of cases across the country without stronger public health measures in place to prevent this. And some of the provinces, they're going back into the red zone, which means that they're closing businesses again. These variants threaten the current trajectory, one which shows the virus coming somewhat under control as of late. We know any resurgence could have potentially devastating impacts on Indigenous communities. Although we do not have the hard data from the Manitoba government, we have already seen a number of rural and isolated Indigenous communities become hotspots due to the high number of individuals per household and other barriers and realities that make their communities more vulnerable to the virus. In revisiting 2009, First Nations were hit hard during the first wave of H1N1, and there were deaths and high numbers in ICU. A nurse who worked in ICU called me to inform me that 80% of the patients in ICU were Indigenous, but again, that was never made public. This was intentional disregard for data collection, and we must ask ourselves why. In the 2009 pandemic, the second wave immediately followed the first wave at the end of August, and the reserves were not as hard hit as in the second wave. The vaccine came out in November, and PHAC acknowledged it lessened the severity of the virus. On my reserve, Brochet, one of the remote reserves, there was one case of H1N1 in 2009, and it was the priest who had gone to Mexico for holidays. He passed on to the spirit world, but there were no additional cases on reserve, although there were pre-existing conditions such as TB, diabetes, overcrowding, homelessness, food and water insecurity, and addictions. During the COVID-19 pandemic, I provided 1 week dental care on 4 reserves over the summer 2020, and there were no COVID cases at the time. Unfortunately, those 4 communities were all hit in the second wave. In January 2021, I did a 2-week clinic in Brochet where there remains no cases as of today. I observed that the people respected the COVID guidelines, and all people returning from outside the community had to quarantine for 2 weeks. There was a lockdown and people coming in were screened and had to be approved for entry by the chief and council. The community had been supplied with an isolation tent, which was fully equipped and comfortable, even at -40-degree weather. The isolation tent had a security guard assigned to it, and the residents had their meals prepared and dropped off. People in Brochet still hunt, fish, harvest medicines and berries, and live off the land. The sharing culture and community strength of collectivity is a source of strength and has healing capacity. In speaking to the people at the nursing station, it was easy to see that they were in good spirits and had the patience to outweigh the virus. I had many conversations with relatives and had a chance to practice my Cree. I think you know that in residential school, our language were taken away, and it's taken me some time to get my Cree back. What I noticed was their love of laughter and humor. As I mentioned, we don't have hard data from the provincial and federal governments. Manitoba is in a unique position of being able to collect data on First Nations and have spent years setting up this system. Ms. Leona Starr is the Director of Research at First Nations Health and Social Secretariat of Manitoba. It's called FINISM. She works collaboratively, locally, regionally, and nationally to ensure that research and information is governed according to protocols defined by First Nations. So this is a very unique research group, and I don't think the other provinces have such a counterpart. The First Nations governance, First Nations principles of OCAP, free, prior, and informed consent, and First Nations ethical principles are the three criteria supported by the Chiefs in Assembly and written into the Assembly of Manitoba Chiefs, AMC. Provincially, there were fewer cases of COVID-19 on reserve in the first wave due to the fast action of the chiefs and councils to lock down their communities. The Manitoba First Nations COVID-19 Pandemic Response Coordination Team Bulletin got information from FINISM, and they stated that as of February 18th, 2021, there are 74 new cases, 600 and this is for on reserve, 627 active cases, 3,676 recovered cases, 298 presumed active cases, 15 current hospitalization, 3 in the intensive care unit, a total of 44 deaths and 345 daily tests. For the off reserve, there are 12 new cases, 135 active cases, and 5,047 recovered cases, 111 presumed active cases, 13 current hospitalization, 1 in ICU with a total of 101 deaths and 97 daily tests. The median age of death for First Nation is 66. For overall Manitoba population, it's 83. Total First Nation cases overall for on reserve is 4,347. Off reserve is 5,283 for a total of 9,630. The First Nations population in Manitoba is 100,645. The 5-day positivity rate for on reserve is 15%, for off reserve is 9%, and for overall Manitoba, it's 6%. So this is, they just sent this to me, so I couldn't include it in the package that I had been sent, but will include it. And I'll get James to send it in. AMC has also hosted many town hall meetings on Facebook to give First Nations across a province the ability to have different conversations with the pandemic response team. AMC also hosted bi-weekly meetings between the pandemic response team, the Red Cross, and the 6 senators, myself included, who represent Manitoba in the Senate of Canada. This was to ensure that we could advocate for them in the event they needed our help. As it was, they were able to handle all the issues that came up. Sometimes too much energy is spent escaping spaces of racism, indifference, and inexcusable ignorance. But AMC was determined to be inspired to find places of good energy and draw from it. It must also be said that the measures chiefs have taken, guided by the strong leadership of AMC Grand Chief and Change Agent Arlen Dumas, have helped massively to suppress levels of COVID-19 so infected patients didn't overwhelm the hospitals and healthcare system. Now we in Manitoba, alongside all Canadians, are waiting for the ever-changing status of vaccine availability to become reliable, as many questions have risen due to the inconsistency in vaccine shipments arriving here in Canada. AMC was strong in advocating for First Nations to be included in the vaccine rollout because there was some pullback from the provincial government that First Nations would not be included initially, and that the federal government should pick up that cost. One of the concern of northern communities, so as we're fighting with the virus, and I said we have multiple pandemics that they have to deal with. One of the concerns of northern communities was the resource extractive industry of Manitoba Hydro, located in northern Manitoba. When the numbers of cases were lowered due to the efforts of the lockdowns by reserves, Hydro wanted to increase their workers back up to 1,000 people on site, and the workers there are always in close quarters, whether they're working, whether they're eating and sleeping. So they have the potential to spread the virus quickly. Yet, due to the concerted efforts of the 3 Grand Chiefs and individual chiefs, including the strategic use of blockades, Hydro had to withdraw that plan. At the same time, the premiers of the Western provinces, BC, Alberta, Saskatchewan, and Manitoba, declared resource extractive companies, and they declared them an essential service, with sites allowed to continue to operate with between 400 and 1,450 workers. So while they considered it an essential service, armed RCMP in Saskatchewan were dispatched to break up a sacred ceremony, a Sundance ceremony, in May of 2020. The chief ordered them off the land, stating that public health orders do not supersede First Nations laws and treaties, and that added that maintaining tradition and ceremony was even more important during the COVID-19 pandemic. At that time, there was a limit of 10 people to a gathering, and at this Sundance, there were 35. People had their temperatures checked, social distancing was followed, and they were advised to self-isolate for the following 2 weeks. Minister Mark Miller, the minister responsible for Indigenous Services Canada, supported the First Nations. A prominent First Nations lawyer who lives in BC but who's banned in Saskatchewan advised the province to keep the constitutional right to ceremony. Around the same time, an extractive site in northern Alberta, Keir Lake, had a coronavirus outbreak that rose to 100 cases on April 15, 2020. These workers were allowed to go home, taking the virus with them to 3 other provinces, BC, Saskatchewan, and Nova Scotia. At least 3 went back to the community of La Loche in Saskatchewan remote north. More than 130 people were infected and 2 died. Only after the outbreak was declared were masks given to the workers at Keir Lake. During a briefing provided to parliamentarians from various departments, from various government officials, I asked the representatives from these departments why the extractive companies were not made responsible for the cost and spread of the virus. I also asked who was the oversight body for resource extractive sites, and there were no adequate responses given. When we're given the data too, there's no mention of any of the resource extraction and what happens in their fields, like the Tsaile Dam in BC, which had an outbreak. Manitoba had an outbreak, and so did the oil and gas. In the 1974 book, The Fourth World, an Indian Reality by George Manuel and Michael Pauslons, Manuel states at page 2, within my own lifetime, I have seen my people, the Shuswap Nation, fall from a proud state of independence when we looked to no man's generosity outside our own bounds, but only to our own strength and skill and the raw materials with which we had been blessed for our survival, to a condition of degeneration, servitude, and dependence as shameful as any people have ever known. I have also seen my people make the beginning of the long, hard struggle back to the plateau that is our proper place in the world. And with my witnessing what's happening, this is our long, hard struggle back up the plateau. And so it gives me great hope. With COVID-19, I was able to see the struggle move out of dependence and to co-design their strategy, and in doing so, assert their authority. COVID-19 has been and continues to be a good grounding experience. By that I mean it gives me time to see the strength of our people and our allies, and to see that we continue to make it through even with all the social and political determinants against us. I have borne witness to a remarkable group of people as agents of change, whether it's scientific, whether it's qualitative, whether it's Indigenous knowledge. I thank everyone that is doing their part. Land dispossession remains one of the core issues, and it came throughout the COVID in Canada, the economic development, the struggle that people have, that they couldn't address some of the COVID that came up in their communities. Because of the Indigenous people's concerns over the cumulative negative impacts of resource extraction on Indigenous lands and individuals, I asked the Senate Committee on Energy, the Environment, and Natural Resources to investigate these impacts. My office has also asked the Auditor General of Canada to investigate these same impacts from an intersectional lens. I have put forward a motion in Senate to investigate the institutional racism and white privilege that exists in the Senate of Canada, and through the motion have asked the Senate to apologize to former students of residential school, and why racism is so important to address for us, to address all the pandemics that we are going through. The root cause is land dispossession, the doctrine of discovery, and racism. There are many other conversations on the Senate floor, and it bears witness to the voices of Indigenous peoples. Indigenous peoples continue to play vital roles as pathfinders and mentors for me. We bear witness that something huge has taken place with COVID-19 throughout the world for Indigenous people, when the Indigenous world as we know it has changed, and we are moving forward as self-determining and autonomous people. And when we see ourselves like that, our spirit and our power, we reclaim that and we move forward. So I thank you for allowing me to speak, and have a wonderful day.
I want to very specifically say thank you for bringing your insight on what's been going on. Hopefully my audio is better now. I want to also extend a invitation. If you are ever here on Navajo, please, I'll trade you some piñons for some Saskatoon berries. But thank you for attending. We'll take a moment. We can take about 1 to 2 questions. If you have any questions, please put them in the Q&A section, and I will read them off. So we'll give the first 3 people, if you have a question. And the question we get is actually, I still can't hear me.
I just wanted to add as well that when this invitation came, it hit me with a special force because the community I live in, that it's Treaty 10, that was signed by the Diné, and that they are related to the Diné and the Navajo. And our community is very rare because we have very many mixed families of Cree and Diné, and I'm related to many of them. So it was an honor for me to come and present. I wish I could see the people that are here present.
All right, we have no further questions. Okay. We want to very sincerely thank you for joining us and sharing it. And please try to stay warm up north and take care of yourself.
Okay, thank you very much.
All right, moving on here. I want to remind everybody, if you have a question, please put it into the Q&A section. We are limiting it at this point to the first 3 questions. We will have a question and answer session at the end of this presentation. Be sure to complete the evaluation of the survey at the end of our conference. And anybody that registers, if you need continuing education, we will have a certificate available if you go online. So next up, I would like to introduce Miss Ramona Antonez. She is currently director of the Navajo Epidemiology Center for the Navajo Nation. She is originally from Eastern Navajo in the Smith Lake community. She and her team have stepped up and stood up to serve with the COVID-19 response. She holds a BSN and a bachelor's degree from Northern Arizona University and a master's of preventative health from the University of Arizona. So with that, I will turn this over to Miss Ramona Antonez.
Good afternoon. This is a sound check.
We got
Great, thank you. And I want to start by saying thank you for the invitation to be here with you today. I want to greet all my relatives across nations by introducing myself. Ramona Yanishedo, Topa Hanishnado, Iroquois Naide, Pashishin, Lokitene, Dashiche, Nana, Iroquois Naide, Dashanala, Do Latesanaz Pasade Ayasinasha. I also want to say Saguli. My father is of the Iroquois Oneida. It is good to hear relatives from First Nations as well. I also spent time in my youth on the Oneida Nation in the province of Ontario. And I just want to share that with everyone here, that I think that when we are working towards health equity and also recognizing our strength here among our people, that a lot of times we have relatives across nations. With that, I'd like to begin with sharing my screen. Let's see if I can do that. All right, so I'd like to ask if you can see the screen here. Is it available?
Yes.
Okay, great. So I will go ahead and start by sharing that the invitation to be here with you today is for us to work on working together tribal nations and communities, with the federal agencies, the state agencies, on sharing epidemiological data. Thank you for the invitation. I also want to share with you that the way we interpret epidemiology or disease surveillance here on Navajo is Nashli Nashka. Our presentation outline for today, I would like to provide a brief overview of the Navajo Nation. I know that I recognize our Natani, our Navajo Nation president, Jonathan Nez, who had spoken earlier, as well as a brief overview of the Navajo Department of Health, Health Command Operations Center, which Dr. Jill Jim had already went over. And I'd like to provide information about the tribal epidemiology centers, specifically the Navajo Epidemiology Center. And then I start to look into more the Kusin Tsaagi States Ada, which is how we interpret Navajo for COVID-19 here on the Navajo Nation, and our partners in working together, the dashboards, as well as discussion. As already stated, and I will go through this very quickly, the Navajo Nation is a 3-branch government, which includes the judicial branch, as well as the legislative branch and the executive branch. Within the executive branch, the Navajo Department of Health is authorized to ensure that quality, comprehensive, and culturally relevant healthcare and public health services are provided on the Navajo Nation. In that, I want to provide the overview of the tribal epicenters, and I want to share with you that there's a link there that you can click on and get a better understanding about the 12 tribal epicenters that are across the United States. And you can see here, I'm going to point to the Navajo Nation here, where we're in the Four Corners area of including Colorado, New Mexico, Arizona, and Utah. And we're very unique in how we have these cross state line jurisdictions, and also seen ourselves as one Navajo Nation. So I invite you to visit this link to the web pages of the sister tribal epicenters. And then as I go into Nashli Nashka, which is disease surveillance, there's a variety of missions, there's a variety of responsibilities that we have here at the tribal epicenter. And one is to monitor health status, also maintaining public health disease surveillance, conducting health research, conducting disease outbreak investigation, reporting health data, providing technical assistance, and assisting with identifying priority health concerns. With that, I want to share with you the vision that we have, that our colleagues and we put together, and that is empowering Diné people to achieve Hojo through Nashli Nashka. Hojo is a state of balance, a state of well-being, not to have access and not to have limitation, but to have that place where there's that balance. It also means many other, such as having philosophies of well-being. It also has implications to our relationships of among our people, which is our clanships, as well as our friendships and partners, through data, collect data, and understanding what we see here on the nation. So just wanted to point you to the Navajo Epidemiology Center webpage. There you will find that there are multiple reports that we have published over the years, and also information and publications with projects that we have conducted here on the nation. As I move to the next slide here, I'm going to spend a little more time on this slide here in looking at how we address the COVID-19 here on Navajo, and working with not only the Navajo Nation, with leadership. I want to stress the importance that we have experienced here on Navajo with our executive branch, as well as our legislative and judicial branch. Early on of the pandemic, we were gathered together to speak about, to think about, to plan as we were monitoring COVID-19 coming into the United States, and as it was getting closer to the surrounding states of the nation. When I say nation, I mean the Navajo Nation, as we were starting to see the spread of COVID-19. We kept in leadership discussions and anticipating how we will respond. The Navajo Nation did declare a state of emergency in March, and we were able to continue to go into organization and response mode. As I go through the branches, each of the leaders were very supportive and working to understand, and then they worked to onboard and also provide education and getting input from the leaders at the division and department levels across the nation. In that particular work, we work closely with the tribal health organizations, which is the Public Law 93-638 healthcare providers here on the nation. Those are part of our partnerships as well here on nation. And I know Dr. Jim had spoken about the healthcare system here on Navajo. I do want to move into the states, and I point here to the importance of data access and data sharing. Prior to this particular pandemic, COVID-19, we at the Navajo Epidemiology Center had data sharing agreements in place with Arizona, New Mexico, and Utah Departments of Health. And we had built relationships with the states prior to this pandemic. And we were in close communication with the states. And I just want to share a brief story here as we were preparing and watching and monitoring COVID-19 as it was coming closer to our nation, that I told our leaders here that our team at the Navajo Epidemiology Center were very confident of our relationship with these 3 states, that as soon as they were confirmed or informed or notified of a confirmed case of COVID on our nation and our border towns, proximity to the nation, that they would contact us. I was very confident in that. I worked to assure that we would be one of the first to know when we were confirmed with the COVID case. And I remember the day as we tell our story, as our story continues to evolve and it continues to be written about this pandemic, that we were having conversations with our local tribal healthcare system here on Navajo. And we started to develop line lists where cases, tests were being conducted. And each time we would get a report saying there's